some national and international faculties who are really expert in their field, and they will going to contribute much about the subject in the webinar with their experience. On behalf of KOA, I would like to welcome Dr. SUNIL Manjunath. He's from our place, Bangalore. He is our guest speaker today. Dr. SUNIL is a professor at Christine Klein Institute of Hand and Microsurgery, University of Louisville, USA. Kleinert is also known as Mecca of Hand Surgery. Most of us know that Dr. SUNIL is from Bangalore and his family still resides in Bangalore. I think he is coming to Bangalore very often to see his family. He is graduated from Bangalore Medical College. He did this master from Hilltop Medical College. He worked as ortho faculty at the MS Ramaiah Medical College from 1997 to 2004. To pursue his career in hand surgery, he underwent fellowship training in NUH, Singapore Kleinert, and Children's Hospital. He continued as a faculty in Kleinert and currently serving as clinical professor. He has received many awards for his work and has written many number of books, and also he has worked on research articles. We are happy and proud of our own colleague reaching new heights with his dedication and commitment. We have our own national faculty, Dr. Anil Bhat from Manipal, KMC. He is also well known to all of us. I think all KOA members know him. And I did not tell much about Dr. Anil Bhat. He is the most active person in hand surgery, and he speaks much about, very good about the hand. He has done a lot of work in hand surgery. He is with us. We have one more surgeon from Bangalore, Bharath Kadadi, my own friend, and Darshan Jain, associate professor from Ramaiah Medical College. Okay. They are also done a lot of work in hand surgery, and all of us are going to have much information and knowledge from them in these 2 hours. I am sure we are going to learn a lot about scaphoid fracture from these speakers. Along with them, there are panelists. A senior most, our past president, Dr. Rajendra, a senior surgeon, and Uday Kumar from Sagar Hospital, everybody knows, and Suryakanth, he is HOD of KIMS, Hubli, and Dr. Vamshi, he himself is a hand surgeon from Sanjay Gandhi Institute of Trauma and Orthopaedics. Especially, I thank Dr. Satish Sarvega. He is a man who is organizing these webinars, and I'm glad to welcome Dr. Bharath, our new secretary. He must be on live. I didn't see him. I welcome him, and he will be here with us, our new Secretary General of Karnataka Orthopaedic Association. Without any delay, we'll start the program because we have 2 hours for the program. I welcome all, and I'll wish you all the success for the webinar. Thank you. Thank you very much.
Dr. Anil K. Bhat will be monitoring this webinar. So please go ahead, sir.
Thank you, Dr. Vamshi. Thank you, Dr. Chandrashekar, sir, for this opportunity from the KOA. And I thank all the KOA members and the KOA office bearers for this opportunity for the hand surgery itself. Again, without much delay, I would like to start the seminar. I would like to invite my dear friend Sunil for his first lecture. There are a lot of myths and a lot of controversies surrounding scaphoid, especially for general orthopedic surgeons. And the first talk is basically towards that, to demystify what is the controversies around the scaphoid fractures. Sunil, the screen is yours.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಕರ್ನಾಟಕ ಹಸ್ತಚಿಕಿತ್ಸಾ ತಜ್ಞರ ಈ ಸಂಘದ ಒಕ್ಕೂಟಕ್ಕೆ ನನ್ನನ್ನು ಬರಮಾಡಿಕೊಂಡಿದ್ದಕ್ಕೆ ನಿಮ್ಮೆಲ್ಲರಿಗೂ ನನ್ನ ಹೃತ್ಪೂರ್ವಕವಾದಂತಹ ವಂದನೆಗಳು. It is always an extremely distinct honor and pleasure to be able to present one's work in front of one's own home audience. I thank you for this opportunity. I'd like to specially thank my good friend, Professor Anil Bhat from Manipal, who invited me to this conference, and my other dear friend, Professor Satish Shervegar from Ramaya, who is the coordinator of this webinar. I also want to express a special word of thanks to Dr. Vamsi, who is extraordinarily efficient in helping us organize this. So without much ado, if you give me a second, I'll just start sharing my screen. I have been tasked today to demystify scaphoid fractures. If we are calling upon someone to demystify something, the first question we need to ask ourselves is, why is the scaphoid such a mystery? The reason is because the scaphoid is a problematic bone. If that is the case, we need to ask ourselves, what are the problems with the scaphoid? What are the consequences of these problems, and how do we solve these? The problems of the scaphoid are many. They're biological, radiological, and biomechanical. Let's start with the biological problems. The first biggest issue here is that the scaphoid has a problematic blood supply. What do we mean by that? The blood supply to the scaphoid in most cases is unidirectional. There's a single vessel which enters at the waist and passes proximal to the scaphoid, which means if a fracture occurs somewhere there, the proximal pole becomes avascular. The next biological problem we face is that the scaphoid has problematic coverings. What does that mean? The scaphoid is entirely intra-articular, which means most of the scaphoid is covered with articular cartilage. That leaves a very little area of the scaphoid with periosteum. The consequence of that is there is ineffective periosteal healing, and hence all healing in the scaphoid has to be endosteal. Then we move on to radiological problems. For that, we first have to understand the shape of the scaphoid, and that itself is a problem. The scaphoid really has no shape. I have been treating scaphoid fractures for almost 25-30 years now, and I have no idea whether this is the right side scaphoid or the left side scaphoid. And I don't know if I'm looking at the volar surface, the dorsal surface, or anything. It has a problematic shape. As if that were not enough, there's a problematic alignment of the carpal bones. They are not in a straight line. They're in the form of an arch called the transverse carpal arch. To add to that, in that problematic alignment, there's a problematic position because the scaphoid is not in the middle of the arch, but it's at the end of the arch. And that leads to a problematic angle. So if you take all these problematic things and put them together, and then you try to take an X-ray, you have a problematic view because your X-ray beam is coming straight down on the hand, whereas this bone has no shape and is located at a completely different angle. In other words, scaphoid X-rays are a problematic view of a problematic alignment of a problematic shape. The consequence of that is that on X-rays, scaphoid fractures are easy to miss. They may not show up acutely. You can't determine vascularity of the scaphoid, and they're difficult to determine union. What about the biomechanical problems? Look at the carpus. The carpus actually comprises two subjoints, the radiocarpal joint and the midcarpal joint. And the scaphoid is the only bone which spans both joints. To add to that, you have the radioscaphocapitate ligament, which crosses the scaphoid right across the waist. This radioscaphocapitate joint acts like a pivot, and the scaphoid flexes and extends on that joint. So you can see that. That's how the scaphoid moves on this joint. What does that result in? It results in very complex problematic kinematics. When the wrist goes into radial deviation, the scaphoid flexes and pronates. And when the wrist goes into ulnar deviation, the scaphoid extends and supinates. So look at the shape of the scaphoid in these two X-rays, and you can see all that has happened is the wrist has slightly radially or ulnar deviated, but the shape of the scaphoid has completely changed. As if that were not enough, we have even more problems. Look at the orientation. We discussed this was at 45 degrees of an angle. So see where the thumb lies. The thumb is not in the same plane as the other fingers, and it lies at an offset. What is the consequence of that? When you have axial forces coming down the thumb, they exert a bending moment on the scaphoid, and this is further aggravated by the radioscaphocapitate ligament. What's the consequence of this? If the scaphoid breaks, the distal part flexes and gets impacted, and that's what you call the humpback deformity. So now that we have seen all these problems and we have looked at all the various consequences of these problems, what are the solutions? We said the problems could be radiological, biological, and biomechanical, and let's see each one of them. On an X-ray, we said a fracture is easy to miss and may not show up acutely. So in that case, your solution is to do a scaphoid view. Here is a plain regular PA view on one side and an ulnar deviated PA or a scaphoid view on the other side, and you can see that the fracture is only showing up on the scaphoid view. So that's your first solution. Sometimes even a scaphoid view may not reveal the fracture. Look at this patient. The PA view and the scaphoid view both don't show a scaphoid fracture, but the patient has severe tenderness over the scaphoid. So what do we do in this case? You have to obtain an MRI. Here's an MRI of the same patient, and on the T1 sequence, you can see a subtle fracture line, whereas on the STIR sequence, you can see significant distal bone marrow edema, both of which tell you that there is possibly a fracture in that scaphoid. Then we said that you cannot determine vascularity on an X-ray. At this point, I want to draw your attention. If you are seeing sclerosis of the proximal pole, that's not an acute problem, that's a chronic problem. In an acute situation, this is how the fracture will look. You're seeing that fracture. Now the question is the scaphoid vascularized or not vascularized? How do you know that? You need to do an MRI with contrast. And here's that same patient. When you look at the with and without contrast images, you can see that when the contrast is administered, the distal part of the scaphoid is picking up the contrast, whereas the proximal pole remains dark, suggesting that though this is an acute fracture, the scaphoid is already avascular. It's difficult to determine union on X-rays, and your solution in that case is a CT scan. So if you have a doubt, you want to get a CT scan. Now the yellow arrow shows that some of the fracture line is still visible. However, the red arrows show that there is a lot of bridging trabeculae seen, which means that this fracture has united. Biological problems. What do you do for poor vascularity? You've got to bring in new blood flow, which means a vascularized bone graft. That means surgery. If your biological problem is a poor periosteum, you have to promote endosteal healing. And the only way you can promote endosteal healing is by rigid compressive fixation, which means surgery. We said that there are complex movements and biomechanical problems in the scaphoid. We can't do anything about the way the scaphoid moves or the offset position of the thumb. That is just an anatomical reality of life. So the only thing we can control is the bending moment on the distal part. So if you want to predictably stop that from becoming something like this, you need to put something across, which means surgery. That leaves only one question: which implant do you use? Can you use a K-wire or should you use a screw? To be effective, you need a fixation which will control rotation, prevent bending forces, spare the articular cartilage, and promote endosteal healing. Now, if you put a single K-wire, you can prevent bending and spare the cartilage if you bury your K-wire, but you cannot control rotation or promote healing. Now, if you add another K-wire, you can now control rotation, but you still don't have compression, and hence you cannot promote endosteal healing. But if you put a headless screw, you will achieve all your goals. Now, whether you put a partially threaded or a fully threaded screw, there isn't much difference. So with that, let's go to the last part, which is management of these fractures. The typical algorithm is that if you have a scaphoid fracture with intact vascularity, if it is undisplaced, you treat it non-operatively with a splint or a cast. And if it's displaced, you fix it with a headless screw. But is this really a perfect algorithm based on what we have just seen? Let us look at some numbers. In the last 15 years in our institution, we have treated a little over 1,000 acute scaphoid fractures. I have personally operated on over 100 acute scaphoid fractures. 40% of them were treated non-operatively, 60% were treated operatively with a headless screw. And here is the union rate. When treated non-operatively, the union rate was 75%, and when operated, the union rate was 96%. Which means if you look at this algorithm, personally, I'm not very much in favor of it. And I feel that we can do the patient a lot better if we fix every scaphoid fracture. However, I don't do that in actual practice. I allow the patient to make their own choice. I tell them that this is the algorithm available. I tell them that the fracture can be treated operatively or non-operatively, but I tell them to know the odds. They have a 75% chance of union non-operatively and a 96% chance of union with fixation. So in summary, remember that the scaphoid is a problematic bone. You have biological, radiological, and biomechanical problems. Remember to always take a scaphoid view so that you don't miss fractures. Remember, you can treat it operatively or non-operatively. Non-operatively, you have a 75% chance of union. Operatively, you have a 96% chance of union if you know how to fix a scaphoid fracture. Remember, if you choose surgery, a headless screw is the best option to fix scaphoid fractures. And remember, if you're not sure whether the fracture is healed, always get a CT scan and look for bridging trabeculum. Now, if you remember all that, then you can take a case like this, which is a transscaphoperilunate injury. And just in case you're wondering where the scaphoid is, that's where the proximal pole is, and that's where the distal pole is. Then you can take something like this. You need to remember all of that, and then you can put it all together and fix all the fractures and fix all the ligaments, and you can end up with a decent outcome. And once you know how to do all this, the scaphoid is no longer a problematic bone. Thank you very much.
Thank you so much, Dr. Sunil, for simplifying all those mysterious myths around the scaphoid. Any questions from the audience, Dr. Vamsi?
So far, no questions, sir.
I would request the panelists, if you have any questions for Dr. Sunil.
Yeah, for Sunil, why MRI and CT? Why not just stick on to CT, which shows the trabecular pattern so well?
It depends on what you're looking for. A CT scan will not reveal acute fractures, because if that fracture is so difficult to find, your trabeculae can sometimes line up, and you are not really looking for a break in the trabecular pattern. If it's a very subtle fracture, you will need to see an MRI with those, what I call signal changes there. CT is a very poor indicator for an acute fracture. While on the other hand, if you're looking for vascularity, you once again require an MRI with contrast. CT is not a good option because the scaphoid would not have sclerosed in an acute situation. However, if you're trying to judge union, MRI is not a good option because MRI does not show bone trabeculae all that well. So CT is a good option. So whether you use the CT scan or whether you use the MRI depends upon what exactly you are looking for in that scaphoid.
Okay, good. Thanks for clearing that.
So I have a question. A lot of studies say that the MRI scan may not be the ideal investigation to assess the viability of the proximal bone in non-union. Do you agree with that, sir?
At this particular point in time, now remember, are they speaking about contrast MRIs or regular MRIs? A contrast MRI is, if you are looking for vascularity, you want to do a contrast MRI. You cannot do a regular MRI because you will, if you remember that first picture I showed where I was trying to show an acute scaphoid fracture, you will see edema, bone edema on a stir image. That is not what you're looking for. If you're looking for vascularity, you have to do a non-contrast and a contrast MRI and then compare the two with identical slices. And then you will see a decrease in uptake. Also bear in mind, you need to have a specialized MRI. Now we have a dedicated hand MRI and we can take sections which are as small as 1 millimeter. The problem sometimes is you use the large MRIs with very small slices. And so you don't really see what you are. So if you're looking for vascularity, you want a contrast with and without contrast MRI and not just a plain MRI.
When you say specialized MRI, is it a 3 Tesla, 1.5 Tesla or something like that?
It's a 1 Tesla MRI, but the MRI is literally just designed for the hand. So the patient is sitting on his chair and only the hand goes inside the MRI. It's designed, you're not using a small coil, but the entire magnet itself is very small. It's at the most, now sometimes we do lower extremity MRIs also, but maybe the patient can push the limb up to the knee. It can't even go beyond the thigh, it's that small. But as a result of it, it's almost like you're doing MR micrography. It's like, it's in a crude way trying to say it's a very precise and small MRI machine. It's about a 1 Tesla.
To do a joint using, we normally refer for a 3 Tesla machine rather than a 1.5.
Now for, actually the Tesla does not really matter for your image quality. I mean, a high Tesla is more for research purposes. Incidentally, the very first MRI which was ever brought into India was brought in the All India Institute of Medical Sciences, and I was there at the time. And it was brought in by one of the physicists who was part of the MRI invention team, which won the Nobel Prize. And I was supposed to do a research on a 3 Tesla. So the increase in your Tesla won't really matter for your hand, but it's more for a research tool. We get extraordinarily good images. In fact, some of my publications, which are based on MRIs, the reviewers have specially asked me to indicate in my paper that we were able to get those images because of our dedicated MRI. You can get extremely good images with a 1 Tesla if your protocols are good and your radiologists know how to read your MRIs.
Okay. Thanks a lot. Thank you.
Thank you, sir.
So, audience question. Someone is asking, how do you manage a comminuted fracture? Do you primarily plate it or still use a screw?
A comminuted scaphoid fracture is not very common. I have seen maybe 10 or 12. If it's actually broken into multiple pieces, it's really difficult to fix it. There are all sorts of plates which are designed for the scaphoid, but realistically they are meaningless. The scaphoid is pretty much entirely an articular bone. You put a plate on that scaphoid, it's like sticking a plate inside your knee joint. I mean, it's not going to work. However, there are some instances where it looks like a waist fracture and then you insert your screw and you're slowly tightening the screw and you suddenly see that there's a longitudinal split which starts occurring. In those instances, I have withdrawn the screw and I have put K-wires. You can put 1 or 2 K-wires and bury them inside and the scaphoid heals. It's just that if you can put a screw, it's a better option, but 1 or 2 K-wires work quite well. I mean, remember, before Herbert invented the headless screw, scaphoids were being fixed with K-wires. So if it's highly comminuted, I mean, if it's too much comminuted, you can't do anything. But if it's a few pieces, you can fix it with K-wires.
Thank you.
Thank you.
Any questions from the other panelists?
Sir, if you have decided to fix the scaphoid fracture, so what is your plan? Whether you do an open reduction or a closed reduction with the headless screw? I
almost always nowadays do an open reduction. Earlier on in my career, I would do all these closed reductions and all those fancy things. I now don't waste my time trying to, if you look at the scaphoid, the most difficult thing is getting your guide wire in that. Once you get the guide wire, then it's fine, you know. So now I just open it because if you try to do closed, if you're going from the volar side, you sometimes have to remove the trapezium to get to the scaphoid. And if you're going from the dorsum, there's a risk you might hit the EPL tendon or one of the extensor tendons there. So Consistently now for an acute scaphoid, my operating time is 15 minutes or lesser. And I always go dorsally, I make an opening and I just, once you open it, you see the scaphoid, the scapholunate ligament, so you know exactly where to put it. And then it doesn't take much time to do it. I don't do closed anymore simply because I think I'm getting old, so I'm getting more and more impatient.
I think it's time for the next talk, Prof. Anil.
Yeah, thank you, Vamsi. Is my screen visible?
Yeah.
Thank you again, KOA, for this opportunity. My job is made a little more easier with Dr. Sunil's talk now. So when a patient walks to you with acute scaphoid fracture, it becomes a clinically significant kind of fracture because it's one of the most common carpal bones which we see. And as being mentioned earlier, the scaphoid, apart from all those problems, also is one which takes very high stress because it basically bridges both the proximal and the distal rows. And another point is that the entire, almost 80% of the surface is covered with cartilage, as Sunil was mentioning. So it limits the ligamentous attachment and the vascular supply and hence complications. So it's a bone or a fracture which is prone for complication right from the beginning itself. Most of them would come with a fallen outstretched hand, but the thing is, most of them, it's a low energy injury. A lot of times patients don't have any kind of swelling or sometimes even not much of pain, and that leads to late presentations. That's a very common problem we see. Initially they have some pain and then they put a splint and then they come back after 2 weeks or 3 weeks later when the pain actually starts. So late presentations become a very common problem here. When you suspect a scaphoid fracture, a good physical examination is very, very important. And if you know, and if you see the scaphoid, which is basically lying oblique there in the wrist, and it has 3 parts. So, and it could be fractured in any of these things. The waist, we always know that classically it's anatomical snuff box tenderness, which you see, but then you always, wrist is a very mobile joint and all these carpal bones can be easily moved. And so you need to move the wrist and see where exactly the pain is. So it's not just putting your hand there and looking for tenderness. The wrist can be moved in all directions, and then your scaphoid, different parts of the scaphoid can come under your thumb. The other point is, as I said, look at all the parts. The distal pole is on the volar side. So it's not just anatomical snuff box tenderness always. So the distal pole palpation on the volar side also becomes very important. A lot of times these fractures sometimes is missed. Even though they heal well, they can also cause problems. And the proximal pole is now on the dorsal aspect. So you have the Lister's tubercle as your guide. And if you go distal to that, just a thumb breadth, you have a sulcus, which is a scapholunate area. And then just radial to that is your proximal pole. So when you physically examine these patients, make sure that you actually examine all the 3 parts of the scaphoid. Apart from that, the tenderness itself, you have certain tests like compression, scaphoid compression test and a resisted pronation test. So these are all things when patient comes to you after 1 or 2 days and you know that there might be a fracture. These are the things which you can do as a physical examination where you can increase the specificity of your clinical yield. So adding all these tests can go up to almost 75%. Then comes the moment you've done this and you know probably there's a fracture, you ask for X-rays. So that is the next step. And it's already shown that the standard X-rays would be a PA and lateral and ulnar deviation for you to get the scaphoid length completely out. And you also add these oblique views, the supinated and the pronated obliques to see at the corners of the wrist itself. And then again, so your yield from the X-rays itself can increase to almost 100% if you're able to see the scaphoid fracture itself. That's when the problem comes. What if the radiographs are not showing you the fracture? Now, almost up to 25% it can happen where the X-rays are not seen, and we know that the classical teaching is to put a cast. So whenever you suspect a scaphoid fracture, treat it like a scaphoid fracture, which means you put a cast, you wait for 2 weeks, you remove the cast, test clinically again, repeat X-rays, and they say because of the fracture surface necrosis, you might be able to see a line, and you decide on that. But then a lot of times nowadays, especially patients are not willing for this. They want a diagnosis and they don't want to put themselves into a plaster for 2 weeks, wait and come back and again have that uncertainty. So as Sunil mentioned, the second line is always a MRI. So we are not again looking at the fracture line here. We're looking at the changes of the fracture, which it brings about basically the edema, the fracture edema and other things. So it's not like you're looking at a fracture line in the MRI, but you're looking at other signs. Plus, you also have an opportunity to look at other injuries, other carpal bone injuries or ligament injuries. So if it's not a scaphoid fracture, it could be a scapholunate injury, which is commonly missed in these radial-sided kind of presentations. And it's got the highest sensitivity and specificity for MRI for acute fractures if your X-rays are negative. So if the fracture line is not visible, the teaching would be to initially slab and cast and repeat the X-ray. Or if the patient is not willing to wait, then you go for an MRI and look for signs of fracture, which basically is fracture edema and change in the bone architecture itself. So if there is no fracture seen even on MRI, then treat it like a soft tissue injury and put them on a slab or a splint for 3 weeks and you can mobilize them. But if the fracture line is visible right from the beginning, you see a fracture line right from the beginning, but you want to know whether I want to operate on this patient or I can go for a non-operative or a conservative management, the most important thing is the displacement and the stability of the fracture. That's very, very important. And that's where the CT comes into picture. So the CT is when you see a fracture right from the beginning, but you want to know more information, then you want to do a CT scan to see for displacement or combination here. And when you ask for a CT, it has to be very specific. The basic CT is done at 3 millimeter cuts, and then you can miss out these fracture lines. So you should ask for a CT where the scan is oriented in the longitudinal axis of the scaphoid, and it is to be 1 millimeter cuts. So that will assist the surgical for your surgical planning. And as Sunil mentioned earlier, it also helps in assessing the healing later on. And if there are any additional bone injuries, it will bring into picture. Okay. So, but then occult fractures or subtle fractures might not be picked up with CT. That's why we advise MRI as a second line of management. So MRI is to diagnose in X-ray negative or occult cases. But the CTs, if you see the fracture line, then to decide on surgery versus conservative approach based on displacement and combination. So the next question is, once a fracture is diagnosed, which ones to treat operatively, which ones would require surgery, and what is the method and implant? And that is determined basically by the stability of the fracture, as I said earlier. Where is the fracture? Is it in the proximal pole or in a waist or a distal pole? And what does the patient want, which is very, very important. If you look at the good old Herbert's classification, hardly there are very few which are stable fractures. The distal pole, the tubercle fractures, and an incomplete fractures through the waist. It's almost like fracture neck femur when you take decisions for scaphoid. They all behave the same way. And most of them are unstable fractures. So what is stability for me? It is basically more than a millimeter displacement. In distal radius, we talk of 2 millimeter displacement. Here we talk about a millimeter displacement, and that's when the CT will help you. If you look at the lateral intrascaphoid angle, if at all it's displaced, if it's more than 35 degrees, it's an unstable fracture. If there's any bone loss or combination, all proximal pole fractures inherently are unstable. Any DC alignment, if there's an scapholunate ligament kind of injuries, and of course, all the perilunate fracture dislocations are very, very unstable fractures. And these are the ones which might require an operative management. So the non-operative management goes basically for stable, non-displaced fractures by cast. We all know how the cast is. The IP joint can be left free, and then the wrist is basically in the neutral position. Short-term cast for 6 to 8 weeks and up to 12 weeks. Sometimes for waist fractures at 6 weeks, we take an X-ray, and sometimes we might continue the cast. And then the almost 85 to 93% of union rate, as long as the fracture is undisplaced and it's a stable fracture, good union can happen in most of these fractures. Now, the surgical treatment comes to picture when there are unstable fractures, as I said, or if it's displaced or comminuted. If patient wants or demands for an early return to work in terms of mobilization, probably yes, and that's when we go for internal fixation. Most of the time, we go for percutaneous technique in an acute scaphoid fractures, either ulnar or dorsal, or we can go for an open method, and sometimes we do an arthroscopic assisted. If patient comes maybe at 2 weeks, 3 weeks, there could be a role for that. And also there might be a role for bone grafting if at all there's combination, and then you want to be safe as a surgeon, you feel safe, you can put in bone graft even in acute scaphoid fractures. Implant has been spoken about, but very small proximal pole fractures or open injuries or multi-trauma situation, KOA still has a role. But otherwise, it's usually a headless cannulated screw, which is much more reliable as an implant. Now, distal pole, there are certain indications for operative management. One group is where there's an avulsion fractures of the radial palmar lip, and these can cause problems. And the other group is an impaction fracture like this, where there's a radial half of the articular surface, might go for a scaphotrapezial kind of an arthritis later on. So probably there is a role for this, but generally most of them heal. The majority are waist fractures, and if the patients are active and young manual workers who wants to get back early, or athletes, or patients with high demand occupations, or patients with preference for early range of motion, that's where we might advise for an operative kind of a management. The percutaneous volar or dorsal is a standard approach now for acute fractures, especially for stable fractures with preference for early return to activity, or unstable. There's a minimal displacement and you can reduce it by close reduction, and then you can put in a percutaneous screw. The most critical point, as Sunil very rightly pointed out, was the entry point in the volar approach. And it's very, very difficult to get this. And then most of your time should be spent on getting the right entry point. And normally in a neutral position, you might not get this because the trapezium is in the way, and you need to hyperextend the wrist like this for you to get to that junction where you can put in your guide wire there. So the central axis is much different, and the only way you can go to the central axis is from the dorsal approach through the proximal pole. Otherwise, from the volar side, it's always, you're compromising on that. You might not really get a central kind of a center point there, the axis of the scaphoid itself. So as I said, spend a lot of time for getting that entry point. So the first step of your percutaneous screw fixation is to get the axis. So both in the AP and in the lateral, you draw the axis, check under the C-arm, and make sure you're right in the center, as much as center as possible. And sometimes we use this 14 gauge needle for the entry point, which you can pin it right here into the cartilage here, and that 14 gauge needle can act as a sleeve for your guide wire also. Otherwise, so this way it can be shown. Otherwise, if you're good enough with your free hand, you can straight away go into the junction where the AP and the lateral axis meets, and that is your entry point. And again, make sure you check in all the planes as much as possible so that you don't create false passages, and you're as much center as possible, and your screw gives the maximum biomechanical strength. If you want, you can actually screen the entire scaphoid 360 degrees. A lot of times people put the hand into the traction tower while they're doing the acute percutaneous fixation, so that the C-arm can rotate all around and they can check the axis all around. So this is the most crucial point, because everything happens now over the guide wire. Your depth, your drill, your screw, everything goes over this guide wire. So make a small entry here. A lot of times some people make the opening like this first and then do the guide wire. You can do that also. Otherwise, you put the guide wire and make a small entry here. Use your depth gauge here now to measure the screw length. And generally, we minus about 4 to 5 millimeters, because, as I said, the scaphoid is completely covered with cartilage, and you have to seat the screw 2 millimeters underneath, plus there might be a fracture gap. So you calculate all these things. So minus about 4 to 5. And drill is necessary. Sometimes the proximal pole can be quite dense, so you'll have to drill that. And then this is the compression screwdriver here. The screw is fixed to this at this point. And this is the first screwdriver which we use. So you go with this screwdriver to about till where the screw is in flush with the outer border of the scaphoid itself. And then you shouldn't be using too much force here. The moment you get some amount of resistance, you stop there at that point and withdraw this. And then you take out this and you go for the next step, which is basically this. You have another screwdriver here. This is one particular system I'm using. There's no advocacy here, no conflict of interest. So there are 3 markings here, it's like a traffic junction, the green, yellow, and the red. So your screw is just suited outside the scaphoid, and the yellow one tells you that it's right now in flush with the scaphoid, the distal pole, and the red one, as you go inside, means that the scaphoid is now seated 2 millimeters below. So this is the basic instrumentation. And again, check in all the 3 views, all views possible, whether your screw is seated well, and especially in the lateral view, that your screw is not longer, it's not penetrating the radiocarpal joint here. Now, open technique is basically in acute displaced fractures where you can't reduce by closed methods, or if there is some combination, then that is the best way. The volar approach is for distal third and middle waist fractures. It also is useful to correct the humpback deformity. It causes the least disturbance to blood supply and gives you good visualization of the entire scaphoid. Only thing is you have to cut through the capsule, so it will cause some amount of stiffness here. And this is the basic approach. All of you are familiar with this approach. Okay, well, that's not playing. But so we go through the FCR sheath here and open up through the ligament here. And the rest of the procedures are same. You come through the scaphoid here and the drill. And then you first you measure the screw length and the drill, and then the same thing. Now the percutaneous technique, what I showed you, is basically being shown as an open procedure, so you can see what exactly happens. So you stop at this point here where it is just about the distal pole. You remove this screwdriver, the compression sleeve here, and then you put in the star-headed screwdriver here, and then check for the same points, and then you see the fracture line here. You can visualize the fracture line here. And the same steps are being done until it's in flush. The green is in flush with this. And once that's done, you know that the screw is completely seated inside nicely. The most important step here in this is, again, suturing the capsule very nicely. That's very, very important. So you can screen, because I'm screening here basically to see for any scaphoid unit instability or carpal instability. That's very, very important after you've done the procedure. A lot of times there might be some amount of scaphoid unit instability in these patients, but have to pin down the scaphoid unit ligament also. So that is very, very important for you to screen after your fixation. And closure of the capsule is very, very important. So when you're opening it also, a lot of people do a Z cut here, or sometimes a different kind of a ligament sparing incision. My preferred way is to just directly go through and through so that it's easy for me to suture it later on. Now, proximal pole fractures, they're all very small fragments, very tenuous blood supply, they're intra-articular location, and a long lever arm, which means they're all very inherently unstable fractures, proximal pole. And the most important or the easiest way to approach them is the dorsal approach, because the screw can be placed in a central axis, and you can do percutaneous or a mini open, which Sunil talked about. This is the percutaneous technique. You need to flex the wrist so that you get the distal and the proximal pole, both the shadows overlapping here. That is the center point. And then the guide wire goes in. But only thing is you can't extend the wrist for you to check the lateral. So you have to come out here and withdraw the wire in flush at this point here, and then do the rest of the procedures. Then you put a screw like this. So that's all. Otherwise, if you don't get that reduction percutaneously, you do a mini open, which Sunil was mentioning, and the rest of the procedure is the same. The screw is there in this. Or if it's minimally displaced, you can use a joystick technique like this and reduce the fracture like this, and then go for this. You can also use an arthroscopic kind of an assisted kind of an approach. You actually, these are for patients who come a little late. You can see the scaphoid here, and then you actually debride that area, and then you can put in the screw. I think my presentation hanged. So that was a last but one slide. So basically, as Sunil mentioned, do you operate on all these patients or not, especially in unstable fractures? So that is a basic question. So we use basically what is called as an aggressive conservative approach. That means basically all patients go for a cast, and at 6 weeks we do a CT scan. We clinically assess them, and if there is some tenderness, we want to know whether we need to put the cast further or we have to operate on them. So we do a CT scan at about 6 weeks, and we measure the gap there. And generally, if the gap is more than 2 millimeters, we advise the patient for a percutaneous approach. And if the gap is less than 2 millimeters at 6 weeks, we tell them go for a cast for further 2 weeks. So most of the time, we pick up these early chances so that they might not have to go for a non-union by this conservative, aggressive conservative approach. So a CT scan at 6 weeks, measuring the gap, and then advising the patient for a percutaneous way would be one of the ways. It's more of like a middle path regime. We don't really operate all the patients, or we don't put all the patients for a non-operative management. So that is the basic philosophy of acute scaphoid fracture decision making. Thank you so much.
Do you have any questions from panelists?
Vamshi, the question to Anil. How many, radiocarpal arthritis have you seen for untreated non-unions?
I have a case discussion coming up, which is similar to that. It all depends on it all depends on when they come. So that is the question always asked. There are non-unions which we see routinely sometimes for when we take an X-ray for something else, and you see a scaphoid non-union, but then it's not still gone for an arthritis. It all depends on a patient's occupation, how badly they're using the wrist, and all these things. So I have a patient now who came 10 years later. So the general natural history of a scaphoid non-union is usually they come back at about 10 years or 12 years or 15 years. So if at all we have followed up these patients long enough, if there's a non-union, definitely they go for scaphoid non-union kind of an arthritis. But the question is when you see these patients. So that's very, very important.
Yeah, but
so,
how many have you seen such arthritis?
We have seen, because for me, it's more of a practice, which is basically referred practice. So we do see a lot of them actually referred because of this arthritis. Okay. So it's not like our patients and we are following up and then we are seeing the arthritis. No, it's for me personally, it's like patients being referred for already who have gone into arthritic change and they do come there. So we do see quite an often these kind of patients.
Okay.
We have a question.
Rajendra.
We have a question from the audience. So someone is asking, why do you wait till 6 weeks to get a CT and fix? Why not plan earlier?
So these are basically for undisplaced fractures or minimally displaced fractures. Not for completely displaced fractures, we would straight away go and operate on them. This is the dilemma between whether we operate on these patients being very aggressive or we put them on a cast. So these are two different spectrums here. So we have patients who are undisplaced or minimally displaced, initially might not be agreeing for surgery. We put them on a cast, yes, but we don't want them to go for non-union. So at 6 weeks is a time where we want to take that call, whether this continue further at 6 weeks, if there is still a gap there, the X-ray still shows a line, and clinically they are still tender. Should I continue the cast for another 2 weeks or 3 weeks or whatever, or even 6 weeks for that matter? Or should I advise a patient a surgery at that time? And for that decision making, my CT scan helps. And the literature supports that the gap there, if you see, which is with more than 2 millimeters, these are the patients who might go for non-union. And that is the time you go for a percutaneous technique. So you're not disturbing the vascularity, you're compressing that fracture area there, make sure there's an implant inside, and you're safe in the sense that it would heal. It's patient's choice again. If patient says no, then it's fine. You put them on a cast and wait. So we have published this where we've got 100% union rate with these kind of an approach, a aggressive conservative approach at about 6 weeks.
And just for the convenience of the people who treat it conservatively, can you tell ideally how a plaster should be put? I'm sure in rural, most of these people will be practicing with the plaster and the correct technique of plaster application.
Yes. There were a lot of controversies, but most of them have been solved. Joe Diaz has RCT on that. And so it's basically a short arm cast. It's not people will ask how short is short. So it's not like, so it's basically, it should involve my principle or basic philosophy is one joint above, one joint below again, which means that you can leave the IP free. The wrist should be immobilized well enough. The lever arm for the cast should be good enough so that it holds nicely. In the neutral position, no palmar flexion, dorsiflexion, ulnar and radial deviation, just about a neutral position, and IP left free, and the classical, glass holding kind of a position. That's just good enough for a cast application.
Thank you.
Dr. Anil,
yes,
I had one case which came after 6 weeks, no treatment given.
Yeah.
It was undisplaced fracture, and he was very sure that I will not, a young fellow, I don't want surgery. Father and son said, I don't want surgery. So I said, we'll take a chance. So we gave in radial deviation. In radial deviation, we put a cast, and I kept it for 2.5, 3 months. It united. What's your comment on that? Undisplaced, but yes, there was a clear fracture line.
Yeah. So for me, it is undisplaced should heal in a plaster. Simple. It's an undisplaced fracture which is quite stable without any other problems should definitely heal, given a chance that it can continue. But it's again putting a cast and keeping the cast for 3 months or 4 months, that is the patient's choice. That's why I said at 6 weeks is the patient's choice. If the patient says, no, I don't want a surgery at that point of time, then yes, they have to be immobilized as long as the fracture takes to heal. Most important, young patients, especially if they're smokers, these are the patients who have problems. There is a delayed union in these patients. So we have to be very careful with these patients, very specifically ask for smoking history in these patients. Otherwise, it should heal. But the other part is that if at all I have a very objective way of looking at it, I do a CT, look at the gap and tell the patient, look, yeah, if it is less than 2 millimeters, it will heal, put a cast and wait for it. That's the way I would talk to the patient.
This fellow had come after 6 weeks. No treatment was done.
Correct. So if it was undisplaced, absolutely no combination, is not a smoker, I think there's a high chance of it to heal, except that he has to put the cast for 3 months or 4 months. Yes.
Dr. Anil, we'll go with your
difference between putting an above elbow cast and a below elbow cast? No difference?
I think, no, it's not required in most of the times. But there in the literature, they say that if the patient is non-compliant, you can go for a above elbow cast. Because there is absolutely no change in the fracture site with your pronation supination. So that way, biomechanically or even the movement wise, there's no difference. It doesn't displace the fractures if it's a below elbow cast. But if your patient is non-compliant, better to put them at least for the first 3 weeks in above elbow cast. That's what some of the literature says. Yes.
Dr. Anil, we'll go with your case presentation. We're out of time.
Yeah.
I've seen that you never used the anti-rotation K-wire for your screw fixation. You never use one?
Sorry?
You never used the anti-rotation guide wire while putting a screw on. Is that a
No.
norm for you? Or
No, generally I don't use that. Is the screen visible?
Yeah.
Yeah, it's visible.
Yeah. So this young male, 35-year-old male, history of fall 10 years back, he came to us. I didn't remember, actually, he came very recently. Actually, we did this case very recently. And he said he had come 10 years back and we had treated him with a plaster. And then he never came back for follow-up. He actually stays in Manipal, and he said, sir, I didn't come back after that and I was fine. And now he comes back telling that he has severe pain in the snuff box area when we examined him. And also along the wrist joint also, he said he had pain. And the range of motion had decreased for him over time. So that's why he actually came, and especially in radial deviation and palmar flexion. So these are his X-rays. Bharath, would you like to take this on?
I'm not sure if it's there. Dr. Bharath?
Bharath is there.
Bharath is there?
Yes. Yes, Anil. Yes.
Yeah.
So how long it's been now after the injury, Anil?
The injury has been for 10 years now.
Okay, yeah, this answers Dr. Rajendra's question as to, have you seen arthritis? So what we call a snack crest, scaphoid non-union advanced collapse. So it can occur anyway from 5 years, 10 years, 15 years, 20 years. So, and there is also a paper which says that by a landmark paper by L.K. Ruby et al. Who says that 97% of the scaphoid non-unions will end up in osteoarthritis. 97% of the untreated scaphoid non-unions, which is also supported by other papers from the literature. So, yes, I can see in this particular X-ray there is a sclerosis fragment. There's a clear, fracture non-union, and also there's a decrease in the radiocarpal joint space, particularly between the radial styloid and the scaphoid. As you can see here, and in the lateral view, there is also a DC where there is a malrotation of the dorsiflexion of the lunate, as you can see in the lateral view.
Sunil, your comments on the X-ray?
Yeah, I agree with Bharath. This is a snack wrist. You can see that the proximal pole of the scaphoid is almost disintegrated. You're seeing radioscaphoid arthritis with a prominent osteophyte at the tip of the radial styloid. The patient also has arthritis between the capitate and the scaphoid. So there's scaphocapitate arthritis. So you've got radioscaphoid and scaphocapitate. And of course, there's a dorsiflexion. Now, that dorsiflexion of the lunate or a DC deformity is something you will observe in pretty much all non-unions. In fact, we even published a series of distal pole non-unions in which the fracture started going into a DC. And that is exactly what I mentioned in my lecture about how that radioscaphocapitate joint starts affecting it. So the distal pole starts flexing because it is bearing all these forces on from the thumb. And the proximal pole starts going into extension along with the lunate. So the proximal pole of the scaphoid and the lunate go into extension, and the distal part of the scaphoid goes into a flexion, leading on to a DC deformity. So this is the dreaded snack wrist or a scaphoid non-union advanced collapse.
Would you like to comment on anything about the vascularity itself?
One sec.
At this point, really, it's irrelevant whether the scaphoid is vascular or not. This is already a snap wrist. So whether it is vascularized or not is not going to change my treatment. That would only become a consideration if I was actually planning to try to fix the scaphoid. With this amount of arthritis affecting both the scaphocapitate, I mean, I'm assuming that the scaphocapitate is also involved. This is not a completely true PA view that you have there. It's a slightly supinated PA view, because the way you know that is because if you go proximal to and look at the ulna, you see that groove running, that dark line running down from the ulnar styloid. Yes, that's the ECU groove. That has to be more radial to the styloid. This is almost ulnar to the styloid. That tells me this is not a true PA. This is slightly rotated. So I can't be absolutely sure about the scaphocapitate joint in this case. However, it looks like there's arthritis there and in the radioscaphoid joint. So consequently, I don't think I'm going to be trying to save the scaphoid. So vascularity at this point doesn't really matter.
Yeah, because that's a very important point, because sometimes we see these patients coming with an MRI and we know that's absolutely useless, because we know that the scaphoid really can't be salvaged. If it is a snack one, maybe yes, there might be a chance that you fix the scaphoid, do a radial styloidectomy maybe, but otherwise beyond that stage, there's absolutely no role for an MRI kind of to see for vascularity. And as you mentioned that now the forces are going more towards the central column rather than this, and this is already involved now. The radioscaphoid joint is involved here. This is the change happening, the first change which happens with the radial styloid kind of beaking out there. And then the arthritis would spread through these joints and finally involve the capitolunate kind of a joint. And most of the time, the radiolunate joint is the one which is spared in the snack. We did a CT actually, just to know, as you were mentioning, the scaphocapitate kind of relationship. So we wanted to know if there's something happening there in terms of the joint space. So that's the only reason we did a CT. Otherwise, again, X-ray gives you the whole picture of what's happening with the wrist itself. Any comments on this?
No, not really. I think there is scaphocapitate problem, and then if you look at the very first CT scan, that proximal pole is in fragments, so you can see it's multi-fragmented. So. Yeah.
Darshan, how would you proceed with this?
First thing is I'll not be able to save your scaphoid, but we would aim to get as much as good movement and grip strength is what I would try to restore it. So in this situation, I would plan for a scaphoid excision and a capitolunate fusion. Probably I will use the distal pole of the scaphoid as a bone graft for this, and ensure that you correct the lunate dorsal approach, correct the lunate DC deformity, and use the distal pole of the scaphoid as a bone graft there and fix him. So, and which will give him probably around 70 to 80% of his grip strength and the range of movement. And
Okay.
add on with a radial styloectomy as well. Partial, I'll have to take that off as well. And if possible,
So if you do a scaphoid excision,
one more thing, a wrist denervation as well, dorsally.
okay. So if you do a scaphoid excision, would you still go ahead and do a radial styloectomy?
This radial stylo, usually I generally don't do this radial stylo. I don't know. It's quite so prominent with your X-rays. If he goes into radial stylo, I don't know. I would prefer to do it.
Okay. So would you, yeah, basically we wanted to stage it first before going on to so I would put it somewhere, where would you put it, Bharath?
Yeah, it looks like stage 2 or 3.
Yeah.
3.
The capital
be
lunate
able to
was, yeah. I mean, on the CT, if you look, the capital lunate looks nice actually. So I would put it somewhere stage 2. Sunil?
I think this is more of a stage 2, but realistically, I don't use this classification at all.
Okay. Okay.
So which is better, PRC with the interposition or capital lunate fusion, as Dr. Darshan said?
So, Peter Stern published a paper where he compared four corners and PRC, and he said that his results were equal in both. Now, Peter Stern was a former fellow from our institute. He trained in our institute and then went and set up practice about 100 miles away, and he's a very big name in hand surgery now. So about 25 years ago, when we heard his talk, we all believed him, and we started choosing PRC or four corner almost equally. We probably do over 100 of these every year. So we have now an accumulated evidence of at least 400 or 500 PRCs versus 400 or 500 four corner fusions. I myself might have about 50 or 100 of each in my series. And unfortunately, PRC does not work as well if you're doing it in young people. I have not had a problem with most of my four corner fusions, but a lot of my PRCs have come back about 8 or 10 years later with radiocapitated arthritis. So I now, if I'm looking at a PRC for a wrist salvage procedure, I almost only use it in very elderly people or low demand patients or patients with rheumatoid, something like that. I've almost, I in fact told Peter Stern that. I said that, he misled me for many years. I mean, he laughed at it, but that is what happens here. If the patient is a very low demand patient or an elderly patient, maybe you can do a PRC, but I generally don't do that anymore in young and active people.
I think that's the natural history of a PRC, because you have a very small surface area for the capitate on the radius. So if the patient is living long enough and then he has a high demand, I think it's bound to undergo the radiocarpal arthritis later on. And that's how we need to take a decision, as Sunil said. Bharath, what's your choices now?
Yeah, younger patients, high demand, I would prefer a partial rate fusion like a capital lunate.
Out of this, what will you choose for this patient?
Yeah, I would do a excision of the complete scaphoid, because the distal fragment of the scaphoid is again abutting over the styloid. So I would remove the whole scaphoid, and then I would do a capital lunate fusion only. Yeah.
Okay.
I wouldn't choose a four corner. I'm happy with doing capital lunate over the last 50 to 60 patients.
Kamsi? Sorry, Sunil?
No, our experience with capital lunate fusions have not been good. Between me and my partners, we probably do 50, 60 snack wrists every year. And capital lunate is the only time when we have actually seen implant breakage, because you still have movement occurring at the lunocapitate joint. Remember, the capital hamate joint is not a very mobile joint, but the lunotriquetral joint is still mobile. So you will be putting a lot of force. And in fact, in my entire career, that's the only time I've seen a headless screw break, is when I tried to do a capital lunate fusion. So that's a procedure, again, which has fallen out of favor. Maybe, our patients here are pretty big 6 feet is pretty average. They're huge. They do a lot of heavy manual work. But I don't think anybody in the Kleinert Institute at this point, unless it's one of my youngest colleagues who just wants to try it, none of us who have experience do capital lunate fusions anymore. We prefer the four corner because it's an extremely reliable procedure. And there's really no difference in your outcomes between capital lunate and four corner. So when you do a four corner, you're actually creating a much more solid block of bone with no movement occurring between the lunate and the triquetrum. So you are better off, I think, doing that in the long run. I mean, like I said, our numbers go into hundreds. So we see a lot more complications simply because our numbers are so large. So, yeah.
So, Sunil, do you use the headless screws for the four corner fusion?
My partner and I, we use headless screws for our four corner. We found that that's the best. In fact, one of my partners published his paper on that technique. And, between him and me, each one of us must have done at least about 100. This is for snack and slack put together. We must have done about 100, 150 each. And we like that because there is nothing outside. These spider plates and other things, we've had lots of problems. We are a quaternary referral center, which means, 40% of my patients are referred by other hand surgeons to me. And we have removed a lot of these other implants like these spider plates and stuff. So I think a headless screw has so far been the safest in our hands.
Okay.
Bharath, in terms of range of movement outcome, is it the same between capital lunate fusion alone and four corner fusion? What's your experience? Outcome in terms of range of movement, yeah.
You're asking me? Yeah. Because remember, the primary radiocarpal movement is occurring at the radiolunate joint. So once you do a capital lunate or you do a four corner, your whatever range of movement you have left is still only at the radiolunate joint. The problem you have is because if you do only a capital lunate, you have left the lunotriquetral joint free, which means there is still a certain amount of VC tendency occurring over there, because you now start putting strain on the lunotriquetral ligament. That can cause a shear force, which can then break your implant. But the overall wrist moment, even whether you do a four corner or any partial wrist fusion, you usually get about 30 to 40 degrees extension and about 30 to 40 degrees flexion. You get a functional range. Some patients will get more, some will get less, but yeah.
So, Darshan, that's what I wanted to show you when you said that beak is quite so
prominent.
Yeah, probably this will tell me what exactly happens once you remove the scaphoid.
Yeah.
And that's one way of looking at it. The second way is, again, looking at the bone itself and seeing what's happening in these. So if you see the scaphoid is almost different color compared to the other carpal bones. It's totally dry piece of bone there, completely avascular. But if you see that scaphocapitate Sunil, it was quite fine. The cartilage was intact there at that point. So that's one. Again, these are the two probable steps for me to take a decision what is to be done. We went ahead and, as most of you said, we did the scaphoid removal, and that's the cartilage there again. And this cartilage was intact with the capitate, and we went for a capital loon. That's a scaphoid which is completely fragmented.
The total scaphoid, both the proximal and the distal fragment. Okay.
Yeah. Didn't retain the distal port. Some people advocate that also, but the entire scaphoid was kind of almost like, just yellowish kind of a bone. And then, as Darshan said, we did the PIN neurectomy. I don't know how much it helps. There's a lot of controversies on that, but since it's in the way, we just did that. And so we chose these three parts: the wrist innervation, scaphoid excision, and a capitolunate fusion based on the age, the stage of the snag, the articular surface involvement, and the demand, the moderate demand. So these were the reasons instead of a PRC, as Vamsi was asking. If you look at the younger age group patient, early snag here, and the articular surface reasonably being okay, and the patient is of moderate demand, I think we need to go towards a partial fusion or even a four corner, and not towards a PRC. That's how I would decide on the patient here. And we did the fusion. the most important to get that good raw surfaces. You need to spend time to get the raw surfaces properly because you have a very small area for fusion here. So very, very important that you get a good raw surface and oppose it nicely. And I've used 2 screws to make sure that the lunate is captured on both the sides. So that's again another important thing. As much as possible, try to use 2 screws, which will give a much stronger kind of a fixation and allows you to get a good opposition and make sure that it's held very nicely. So 1 screw comes straight from here and 1 comes from the dorsal aspect, and this way I think it becomes more stable mechanically for the fusion itself. Sunil, your comments?
No, I think it's a good fixation, and it's good that you were able to demonstrate that the scaphocapitate angle was good, and that's exactly what I mentioned when I looked at that X-ray, that it was not a true PA, so I can't really comment about the scaphocapitate, and I don't know how many of the people in the audience realized what I was saying. I was able to point that it was not a true PA based on where that U groove was located. So you have to be careful about what you comment based on the X-ray. That's why I put that caveat that I don't know about the scaphocapitate because it's not true. But I'm happy. Yeah, in this case, I was just looking at your video where you were demonstrating movement of that, and it looked like you already had a stable fibrous union. I was just wondering how whether this patient was really even symptomatic. That video showed that the scaphoid did not actually move as 2 pieces; it just moved as one. Yeah,
this one, right?
Yes. You see, that scaphoid is moving sort of as 1 piece. So I think it's a stable fibrous union. I don't know if this patient even had any problems at that. So maybe even you could have just done only a styloidectomy and got away with this, possibly.
No, but it was avascular. It was avascular. When we saw there's absolutely no bleeding, we curated nothing. And it's almost yellowish. So those kind of scaphoids are completely avascular, fragmented. And you can make out that it's a kind of a dead bone there.
I think it's a very nice fixation. I mean, it looked really good on X-ray. Nice.
But Anil, we'll go with the next talk.
I think
you're over.
The next is again from Sunil, understanding scaphoid non-unions.
So, thank you again for the opportunity. It's always been my mission whenever I give a talk to try to make things as simple as possible. And I generally get invited around the world with this specific caveat as trying to make everything as simple. So simplify, demystify, understanding, make it practical are all standard ways that I'm generally asked to give a talk. So our mission now is to understand scaphoid non-unions. Well, the first question we need to ask ourselves is, why is non-union so common in scaphoid fractures? We have already looked at a few of these. That's because the scaphoid is a problematic bone. And I'll just repeat a few things. We have problems which affect healing, and we have problems in recognizing the fracture. So if you don't recognize a fracture early, it doesn't heal. So you kind of have this self-fulfilling slippery slope of a spiral which it creates. We said that the scaphoid has limited periosteal covering, which affects healing. It has a unidirectional blood flow which can get disrupted with a fracture, which affects healing. You have all kinds of complex forces acting on the scaphoid, which affects healing. And you have this kind of a situation where even when you do a PA or a scaphoid view, you may not see the fracture and you may miss it, so you may not treat it, and that affects healing. Sometimes a patient may present after a second injury, and this is a dangerous situation you've got to be careful about. So now the question is this an acute fracture or is this a non-union? Now it's very important for you to recognize this because otherwise you might treat it wrongly. There's a blown up view of that scaphoid and the yellow line shows the fracture line. But if you observe that X-ray carefully, those little blue arrows are showing cystic changes. So in reality, this is an acute on chronic injury where the patient probably had a fibrous union of an old scaphoid fracture which had not healed and then subsequently tore through that fibrous union. So this in reality is not an acute fracture, it's a non-union. And if you miss this, and if you start treating this like an acute fracture with just a splint, you will fail. And that's why recognizing this is important. Otherwise, that will affect healing. All of this creates a perfect storm, because on the one side, you have poor healing problems, and from the other side, you have a poor diagnosis. And when those two meet, you end up with non-union. Well, so what? So what if the scaphoid goes into non-union? Why should we even bother about it? For that, we have to begin by looking at the radioscaphoid joint. The radioscaphoid joint is at the distal end of the radius. So look at the distal radius and you will realize it has two parts. There's a lunate fossa and a scaphoid fossa. Now the scaphoid fossa is shaped like a spoon. The proximal end of the scaphoid is also shaped like a spoon. And the scaphoid fits in the scaphoid fossa to form a spoon-spoon joint. Spoons are a problem. What do we mean by that? Spoons are too perfect a fit. Look at these two identical spoons. I'm showing you what you would call a PA and a lateral view of this joint, and you see this is a perfect joint with perfect congruity. But even a slight change can spoil that fit. I have just moved one of the spoons by 10 degrees, and now when you look at it from the lateral side, this joint is completely incongruent. So this is one of the reasons why you want to treat a scaphoid fracture. Then we also discussed that the scaphoid moves in all these mysterious ways with complex kinematics. Add to that the fact that when there is a scaphoid fracture, you can end up with an intrascaphoid humpback deformity. You put all these three, and now you have a perfect triple storm. On the one side, you have a spoon-shaped joint, which is a problem. On the other side, you have complex kinematics, which are a problem. And then in the middle, you have a deformed scaphoid itself, which is a third problem. And all the three of them, when they get together, can lead to arthritis. So the important message here is don't ignore scaphoid non-unions, and also don't ignore acute scaphoid fractures, because if they go into non-union, you will end up with an arthritis over time. Now let's analyze scaphoid non-unions. We begin by classifying them. In my opinion, a useful or a meaningful classification should be both simple and practical. A simple classification is one which is easy to remember, and a practical classification is something that we can use for treatment. I classify scaphoid non-unions into 4 types. This is my classification. Type 1 is when you can see the scaphoid fracture on the X-ray or the non-union on the X-ray, but when you open it, a thin fibrocartilaginous shell has already formed around, so you can't really see the fracture intraoperatively. In type 2, that shell is disrupted and there's actually an opening of the fracture site or a humpback deformity. Type 3 is when avascular necrosis has occurred, and type 4 is when arthritis has occurred. Here's a patient with a type 1 fracture. As you can see this fracture in the non-union on the X-ray, but when I opened this patient, I could not see the fracture line at all because a fibrocartilaginous shell had already formed around it. Here's a type 2 where you can see an obvious disruption of the scaphoid with a humpback deformity. This is a type 3 non-union with avascular necrosis of the proximal pole. And this is a type 4 with severe arthritis or a snack wrist, which we just saw a few minutes ago. So how do you manage these? Let's look at the first 3 non-unions. I will come to the arthritis later. Each of these has their own peculiar problems. Poor healing potential is a common problem across all the types. In addition, type 1 is a potentially unstable situation. Type 2, the fracture is unstable and displaced. And type 3, there is avascularity with displacement. For poor healing potential, you always have to put bone graft. So irrespective of what the non-union is, you will need bone graft. In addition, for type 1, you'll have to do an internal fixation. For type 2, you have to reduce the fracture and then do an internal fixation. And for type 3, you'll require a vascularized bone graft with internal fixation. So if you want to just harvest simple cancellous bone, where do you harvest it from? Now in 2016, I published my technique of harvesting distal radius bone graft from the second extensor compartment. Now, for all my publications, I always give my fellow the first authorship. So this is my technique, but my fellow at the time, she's from the Ukraine. So she published this paper, wrote this paper with me, where we describe this technique. So you can make your incision for the scaphoid and then just extend it proximally for a bone graft. Then what you do is you go to the second extensor compartment. Now you can already see the scaphoid and you can see the guide wire in the scaphoid. So you do an extensor retinacular flap over the second compartment. Then you retract the extensor carpi radialis longus and brevis muscles to expose the distal radius cortex. And there you can make a cortical trapdoor. And through that cortical trapdoor, you can harvest bone graft. So this is my preferred site for simple cancellous bone graft for all my scaphoids. Then how do you manage type 1 fractures? Here, the fibrocartilaginous shell is intact, so you do not want to disrupt this because now you already have a smooth articular surface, which is what you effectively want in the scaphoid. So don't damage that smooth articular surface. So I again published another technique in 2017. This was one of my fellows from Turkey. He wrote this paper with me, where I use internal bone grafting for treatment of scaphoid non-unions. What do I mean by that? When you expose that fracture, you don't open the fracture non-union side at all. You make a drill hole through the entire length of the scaphoid. Then what you can do is you can insert a curette through that drill hole and you can curette out your non-union side. Then what you do is you take your bone graft like I just showed you previously, and you insert the bone graft through the drill hole, and then you can fix the fracture. Here's the pre and post-op CT scans of that patient where you can see good union after internal bone graft. Sometimes I have done internal bone grafting even percutaneously or through a tiny approach like this. In these cases, I use a bone marrow set and I use that trocar to harvest a nice core of bone graft as you can see there. And then you can insert it the same way through your drill hole and fix the fracture. And here's a patient who was treated with a percutaneous bone graft where you can see the fracture has gone into good union. What about type 2? Well, here the fibrocartilaginous shell is disrupted and the fracture is displaced, so you need reduction. What you can do, and if the fracture is so displaced and angulated, is you can insert 2 K-wires to use them as joysticks. Then you can use that to open up the fracture site. Then you can insert a curette and clean out the fracture site. You then pack it with bone graft, reduce your fracture, and you fix it. What about type 3? Here, vascularity is disrupted, so you need a vascularized bone graft or a one. My preferred is always the 1-2 ICSRA or the Zeidenberg technique. Now, coincidentally, Dr. Zeidenberg sent his son to train with us, so Junior Zeidenberg was my fellow. But anyhow, so I prefer the 1-2 ICSRA for my vascularized bone graft. So here's a case of avascular necrosis and non-union. That is the 1-2 ICSRA or the 1-2 intercompartmental supraretinacular artery. That's the vascularized bone graft that has been harvested. And there's the fracture, which is now healed and revascularized with an excellent final result. My post-op protocol is very simple. I treat everybody only in a thumb spica brace. Now, whether I'm treating the scaphoid operatively or non-operatively, I only use a thumb spica brace. I do not use casts. In fact, I do not use casts in any fracture at all. I think for the last 10,000 fractures, whether it's distal radius, carpus, metacarpal, or phalanx, I only use a brace. We recently presented about 850 metacarpal and phalangeal fractures, which were only treated with a brace. So anyhow, my preference is just to put them in a brace after surgery for 8 weeks. And then to remind you again, X-rays can be misleading. So I always get a CT scan at 8 weeks and I look for bridging trabeculae. I need to see at least 25% or more. Here's that same CT scan, which I showed you earlier, showing bridging trabeculae. And here's another patient where you can see that there's a nice cortical bridge that is already formed with trabeculae indicating union. What about type 4? That depends on how bad the arthritis is. If it's early, you can just trim an osteophyte, or if it's late, you need to excise the joint. Here's a patient with very early radioscaphoid arthritis, along with the scaphoid non-union. So all I did in this patient was I was still able to salvage the scaphoid. So we fixed the scaphoid and did a radial styloidectomy. And if you look on the picture on the left, the first X-ray, you can see that little bone graft site where I took a bone graft to put into the non-union site. But what if we have the dreaded SNAC risk that we just saw, the scaphoid non-union advanced collapse? then the X-ray starts looking terrible like this. And as we discussed, my preference is always to do a scaphoid excision and four-corner fusion, because over the long run, with hundreds of cases in our belt, we found that these give us the best long-term predictable results. Here are some numbers. For established non-union, in my hand, the overall union rate is about 83% when I treat these. For type 1, I was able to achieve bony union in 86% and a stable fibrous union in 14%. So actually, none of these patients in a type 1 fracture ended up needing a second surgery. In type 2, bony union was in 81%, 13% had a stable fibrous union, and 6% of patients required reoperation. In type 3, where there was an avascular necrosis, fracture union was achieved in 83%, stable fibrous in 12%, reoperation rate in 5%. However, strangely, 94% of these, the scaphoid revascularized. So even though we got revascularization in 94% as proven by MRI contrast, union occurred only in 83% of cases. So in conclusion, if you look at the overall numbers, whether it was type 1, type 2, or type 3 fractures, our union rates were roughly the same. The overall was 83, but they were roughly in and around that 83-85% range, which means that the type of non-union helped me decide which surgical procedure to choose. But for some strange reason, no matter what we do, we are only achieving about 85% union. And combine this with the fact that when we treat acute fractures, we're getting about 95-96% union surgically and about 75% union non-surgically. This tells us is that we still do not know all the answers to scaphoid union. And that is a humbling thought. Thank you very much.
Thank you, Dr. Sunil. We'll take the questions for both the non-union talks later. I invite Dr. Darshan for his talk on management options for scaphoid non-union. Darshan, please share your screen.
Is it visible? Is it visible now?
Yes.
Thank you very much. I'm honored to be a part of this society and speaking about management options on scaphoid non-union. And considering a lot of already has been discussed, but I would run through the existing literature as well as some of my cases, which with the case scenarios, how to go about this. So most important is when we start a topic, what is the definition of a non-union? So when you're talking about what is the definition of a non-union, you always want to know what is the current literature or what are the papers want to look at it as. So failure to unite in 6 months or more after injury with no signs of union or no signs of consolidation, even to 3 to 4 months has been considered as a definition of, or majority of papers are accepting this as or working on this modality. And what is the prevalence? Almost like Rajendra sir was asking, how many of them are really symptomatic or asymptomatic? This one of this paper showed the Sehat and Bannister, which is like 0.14% are asymptomatic. And some of these fractures are identified and treated this was another paper by Dias where he mentioned that fractures are identified and treated non-operatively with adequate follow-up and which progress to non-union was almost 12%. And a lot of times, which is identified as a second injury when the patient falls for some other reason, and then you take up an X-ray and then the non-union is discovered or imaging for any other purpose of the wrist, you end up identifying this as a scaphoid non-union. So 5 to 20% of them really go out to non-union after a non-surgical management, and overall it's almost about 15.5%. So it can be graded based on the location, deformity, and the vascular status, which has already been discussed on so many of them. So what happens to these untreated scaphoid non-unions? This was another question which was, so they present mainly with pain, loss of wrist motion, and arthritis in all symptomatic patients with non-union at the end of approximately 8 years. This is the one of this paper by Ruby et al. So he gives on an average about 88 years is following an injury, they set into arthritis or the snack wrist where it goes into. And it progressed despite initially asymptomatic, it generally tends to progress. So my topic here, I would like to prefer, because snack topic itself is another big topic. So I would like to show the various types of non-union and then talk about those. So that is what in symptomatic patients with non-union. So imaging as few of them. So the majority of these are initially what we do is X-ray, PA view in ulnar deviation, a lateral view, and 45-degree pronation and supination views gives us a full profile of the scaphoid, or relatively a better profile. Then CT, when do we ask for CT? So we ask for CT to know these things, that is site of the fracture, the configuration, or how the fracture line is, the displacement to know, and finally to know the union status. Then what is the role of the MRI? MRI, whenever you want to know the status of the proximal pole, gadolinium that's a contrast and is the most preferred. There are some papers which also mention about the dynamic gadolinium is also useful to quantify, but dynamic is difficult. But in general, we ask them to show a contrast MRI, which gives us an idea about the proximal pole AVN. And a word on the humpback deformity. When do you call this as a humpback deformity? That is a flexed intrascaphoid. That's two lines are drawn along the distal pole and the proximal pole. And an angle which is more than 45 degrees is considered as a humpback deformity. Normally it is 24 degrees. So there are various classifications, as Dr. Sunil was mentioning, that what is a practical classification, what he mentioned to decide your plan. So this is another classification, quite old, but this also gives us some idea about the management or this thing, and which is quite frequently quoted in a lot of papers. So delayed presentation, that is 4 to 8 weeks, is scaphoid fractures, that is grade 1, and grade 2 when the cartilaginous shell, he was telling, the fibrocartilage shell is intact. And grade 3, 4, 5, they basically mention about the resorption at the ends of the fracture non-union side, that is less than 1 millimeter, less than 5, or 5 to 10 millimeters. And finally, the pseudoarthrosis, gross fragment motion, which Dr. Anil was trying to show in his dynamic views, and his comment that it looks as a stable union, but still some of them can have pseudoarthrosis, which when patient complains only we can pick it up that these movements are painful. Again, they are subclassified into proximal pole non-union and avascular non-union or ligamentous injury along with it, or deformity. These are another subclassification which has been used. So without these are quite complex. So I would what Dr. Sunil was mentioning was a reasonable approach to go into identifying this. So these are the parameters when you're considering or when you're talking to the patient, what are the things you are going to look into, because you need to tell them when the patient, because all these patients will ask, what is a guarantee? What is a union rate? So these are things which you need to take in mind before deciding on the surgical or venturing into. That's the length of the time and non-union, what has the duration it has been present. That's one thing which you need to. Age of the patient, amount of pain, because the longer the length is, the longer means these, as I told, like 8 years, 10 years, the non-union state, the achieving union could be a problematic. Age of the patient and any other comorbid is also an important factor. So general principles in management of any non-union is that is the duration, what we look for, the site, as I told, and the approach or the exposure, what you want to prefer, what would be preferred. That's almost a waist and distal pole as well. You want to do a volar approach, and a proximal pole, you prefer the dorsal approach. And the type of graft, there's a lot of papers which suggest which graft is better, or eventually they evaluate and finally go to say that none of these grafts are superior over that. They almost give the similar results. So let us go. And what are the fixation options? The aims of surgery is restoration of the length, the alignment, especially these tend to have a disc deformity with a lunate. So you need to get the alignment of that proximal carpus row as well, stability and compression and osteoinduction and osteoconduction. The goals of fixation, that's an excellent reduction. You need to have that fracture site, that is increase the contact area. The fracture site compression, that is very critical for this. That's why in a lot of papers, previous papers which comment on KOA fixation, various techniques of vascular grafts, but still they have failed because those papers were mainly focusing on KOA fixation, even though their grafts were vascularized. So fracture site fixation is quite important. It's a site of excellent compression should be achieved that prevents the synovial fluid ingress. Primary bone healing should be achieved and reduces the fracture site instability. What are surgical options? So when you talk about surgical options, this is how I look at as established non-union based on the criteria, what I took it as 3 to 4 months, no signs, and 6 months, absolute no union, long-standing non-unions, or non-union with proximal pole with AVN. and previous failed surgeries. There's another segment which is which we get to see here. So preferably you can treat these two as identically as established non-union long-standing. So established non-union options of management are, these are the options like screw alone fixation. There are a good number of papers which say established the screw alone fixation is good. Cancellous graft and screws, whether it's non-vascularized or vascularized, I'll discuss about those. Arthroscopy assisted finally. So this is one paper which was like, there are many papers on this screw alone fixation who advocate just screw alone fixation. What was the rationale mainly? Percutaneous reaming may sufficiently debride that fracture site, and they say that will be successful to place the screw inside, and there's no need for open debridement. And foregoing a grafting may result in less surgical morbidity. These were the proponents of when they wanted to show this. And there are several authors suggested that the stable fixation and well-aligned and a vascular non-unions requires only rigid fixation. So these were the rationale. So when can we consider this screw alone fixation is another thing which we need to know. So typically a delay in treatment less than 1 year. I don't do this for a 1 year as well. So usually I tend to do screw alone fixation whenever there is probably a 2 months duration. That is the time alone I use as a screw alone fixation. However, you have to take in mind whether you treat this as a non-union or just a simple fraction scaphoid. And an undisplaced as demonstrated on a CT scan, no humpback deformity. That is less than 1 millimeter displacement, and a stable fracture fixation. That's a waist fracture, no fracture site motion on live fluoroscopy, like what Dr. Anil Bhat was showing. That was the no. These are the ones which you can consider as screw alone fixation. And no signs of avascularity in the proximal pole, sclerosis, or a questionable finding in magnetic resonance image. And minimal to no bone resorption, that is 1 to 2 millimeters or less than 1 millimeter. Next is, what is a bone graft option? So you can use from the distal radius, you can use from the iliac crest, and finally olecranon as well. So these two are the most commonly preferred I prefer these two as bones grafting options. So vascularized is another option. That was a non-vascularized. When you're talking about non-vascularized, there's plenty of vascularized options. As Dr. Sunil was mentioning, this is the most commonly preferred. Even I prefer 1 to intercompartmental. Intercompartmental supraretinacular pedicle artery. These are the other which is mentioned, that's pedicle artery based on the volar carpal artery and the dorsal capsular pedicle. Free medial, this is a salvage, this is totally a microvascular stuff. That's where you can take a free medial femoral condyle graft, also an osteochondral graft, which is possible. I have no experience with the last one. So I will show a few example on this 1 to intercompartmental graft. So this is the example for the pedicle. This is basically a pedicle which is based on the radial artery. You take, this was described by Matholan et al., where he take the graft from the distal radius, just distal to the pronator quadratus based on this, and you can place on the, this is a volar approach, you do it, and you place this. And the another one is the dorsal capsular pedicle, where this is, I don't do this. I usually prefer the 1 to intercompartmental. And the last one is the free medial femoral condyle graft. This is, you can use as a free condyle as, or even when you want a osteochondral graft. So when I was looking for these articles, literature, then what was the outcome of the bone graft surgery for a non-union of scaphoid? This was one of those articles which this study was mainly in a European study where they had almost 462 patients which were recruited. Union was adversely affected. This was one thing which was common among a lot of papers, that union was adversely affected by smoking and the time between injury and the non-union surgery. So this point we need to note it down when a patient presents to us and when he asks about what is the success rate. And the type of bone graft, the vascular versus non-vascular, or the iliac crest versus distal radius, they found did not appear to influence any of these grafts. That's what they quote. There's another treatment of scaphoid on systematic review. This is the existing, one of the existing evidence which was published in 2015. They compiled 48 publications, vascularized bone graft superior to non-vascularized. Distal radius and iliac crest had similar union rates, and there was no fixation type which was superior, which was some surprising this thing. So there's a lot of confounding factors which we need to take, because this is under 48 publications, so many authors with so many ways of fixations. So can't really give so much of weightage to the study, I felt. But what are the factors which influence the outcome? This is one thing, is smoking and the time interval between, which is quite, even I found some of, in my cases where I found the smoking and the interval between the fracture as well as the non-union surgery definitely affects the outcome of the surgery. To go rush through the procedure, but some of these have already been showed. So this is a preferred approach whenever this is volar on the distal or the waist, when you want to correct the humpback deformity. This is a volar incision you take. That typically, this is the ligament which we all want to protect. After you divide it, and again you want to repair this exactly like this. So you need to restore this ligament, this attachment, and you want to open up this fracture non-union site. Finally, you can use the various bone grafts which are option. This was the Rassi, which was mentioned, the corticocancellous, plain cancellous bone can be fixed, and you fix with a screw finally. And this is the way you correct the humpback deformity. You open up and you put a wedge of the bone graft volarly to correct. So all humpback deformities, you ensure that you go volarwards to fix it. And what is the site of the screw fixation? This is the lateral 1/3 and medial 2/3. This is the site you want the entry point of your screw axis, aiming towards the distal proximal pole of the scaphoid. So these are the various axes which has been mentioned. Dr. Anil was mentioning how to get the entry point. So you want as as dorsal the entry point. You want this because this is the tubercle, so you tend to go air on this side, so you want the compression along this side. These images have already been discussed by Dr. Anil. So this is skin incision what I use. So that's FCR sheath. Once you FCR, then you go to that's FCR sheath. That's the ligament what you see, the RSC ligament. You divide that. Then that's a non-union site. And that's a proximal pole and the distal pole. And that's how you open that. Okay. To place the graft. So this is one of the such cases wherein you can see the non-union. This is typically along the waist. That was a typical procedure what I do commonly. Put a bone graft there, and this is an axial this thing. So I tend to prefer either iliac crest bone graft or the radius here. So this is the post-op X-rays, and this is the 8 weeks follow-up. So some of the pearls of these is pre-op CTs can give more info on the fracture orientation, carpal alignment, and the scaphoid deformity has to be corrected by using K-wires as a joystick. And adequate preparation of the non-union site is quite critical to achieve union. And central placement of the screws. And you could use a supplemental K-wires whenever you're suspecting a carpal alignment or unstable non-unions. This is another case where a 1-2 intercompartmental supraretinacular artery you use. This is typically preferred whenever you have a proximal pole non-union. And when the fracture site is at the proximal 1/3 level, that is where I tend to use this. So this is a very small fragment. You can see this is a so tiny fragment, and the union duration, non-union duration was almost 6 months. And he was been trying out with, this is the MRI, which showed the proximal pole non-union as AVN as well. And this is a typical approach. I don't take a curvilinear incision. I take an incision on the dorsal longitudinal incision along the third extensor compartment. And that's a non-union site, how you expose it. And this is a bone graft, which is based on it's a distally based pedicle. So typically this is the vessel where I see there's a dorsal approach, and this is the vessel what you take. So this is a graft where I harvested, and this is the pedicle based on that. And this is the screw fixation. That's a dorsal approach, the bone graft, the pedicle based 1-2 intercompartmental artery, and the screw fixation. 12 weeks follow-up. This is the union you get. So some of these tips, whenever the proximal pole is so small, so I tend to use a vascularized for a proximal pole and a smaller screw, that is the diameter. Usually the most commonly used for scaphoid fracture fixation is 2.4 millimeter. Whenever you have a smaller fragments like this, you have to try to use a 1.8. Sometimes even this may not fit, then only K-wires is an option for such situation when you're using a vascularized. Only the duration of immobilization might be longer, but that will be the only option. Even 1.8 millimeter may not fit. And this 1.8 millimeter is not available with all the companies. So you should ensure that what companies do have these 1.8 to keep in your armamentarium. So let us look at the evidence as well. So this is what is the evidence for the vascularized bone graft, because there's mixed opinion, because initially all those who were proponents of vascular bone graft for all the AVN fragments, now they say only proximal pole, that is a proximal 1/3 fragment, that is where you use a vascularized one. Rest all we could be managed with a just simple bone grafting, either from the iliac crest or the distal radius. So this is the most non-vascularized, even now non-vascularized bone graft is the most common choice in United Kingdom. That's most commonly used. Vascularized bone grafts appear to be used most frequently for proximal pole, as I told, and but not waist, only as I told, the proximal pole, that is what is the most commonly preferred vascularized bone grafts. So we do even arthroscopy assisted. Typically these are not advisable whenever you find a lot of cysts or too much of a gap non-union. So this, you can see there is a sclerosis at this end. This was almost 8 months following the injury. So this is what we do. That is the non-union site identification through the scope. This is, I am viewing to the mid-carpal site. Then I need to freshen up this. Once I freshen up this, you can see the surfaces, two of these, both the distal and the proximal surfaces. With the arthroscope, you curate it and debride it well, so that you can instill the bone grafts. So I take refined needle bone grafts, means with the Jain needle, where you get really compacted cancellous bone. You get, this is very good cancellous bone where they are well compacted, and instill to that, to the portal, an accessory portal you make. So you instill through that. And this is finally, you could go through a volar approach or a dorsal approach. You could even fix with this the same dorsal approach through one of these portal as well. That's a minimal scar. So this is what typically the post-op, 2 months follow-up. And this is one such paper where PC Ho quite strongly proposes wrist arthroscopy for management of a lot of these stuff. A thorough assessment, he says these were the claims made by the thorough assessment of the wrist. Favorable biological, quite, I say this, the second and the third point is quite acceptable, but thorough assessment, I think with MRI, you should be able to make off what are the issues with any other ligamentous injuries, if at all they are associated with. So this is a typical treatment algorithm, what we can follow for any of these non-unions. That's a delayed union, a non-union you see, that's mini open or rigid fixation with headless compression screws. An established waist with no deformity or fibrous non-union with a sclerotic non-union, then you prefer a open repair. You could use autologous dorsal or volar bone grafting or arthroscopy assisted. And a humpback deformity, you would always prefer to do a volar approach with a Matty or Rassi with integrated, and it is again with a rigid fixation. And the proximal pole non-union with which is viable. Still, some of them prefer the open bone grafting with headless, but I always prefer a vascularized bone graft, irrespective whether this proximal poles, especially when comprising of the proximal third of the scaphoid. And there's another subset of non-unions, that is scaphoid non-union with implant C2. Maybe I will show discuss with the next case when I discuss with this. Thank you. You want me to go with the case as well, or finish off the case as well, or?
Yeah. You can go ahead with the case so that we can discuss all the concepts of non-union with your case.
Yes. Okay. Thanks. So this is one case. 25-year-old man, pain in the right wrist, underwent surgery for scaphoid fixation 9 months back. Still he has pain. Now has pain in his wrist and mild swelling. Range of movement, dorsiflexion 80 degrees, palmar flexion 80 degrees, and terminally painful, he says. These are the X-rays. Yes, it's open for the discussion now. Anyone wants to take up this? How would you like to go in for? What are the preferences? The panelists or the speakers, please.
Sunil, would you like to start with this?
Yeah, so in this case, it's pretty obvious why this fracture went into non-union. That screw is extremely short, number one. So if you look at the very first X-ray, you can see that that screw is barely engaging the proximal cortex. Number two, you can see that the threads are still in the fracture site, which essentially means that this screw ended up acting as a distraction device rather than acting as a compression device. So that's probably why this went into failure. Now, what you're seeing are the after effects of inadequate fixation. because what you're seeing here is, like I told you, that screw has a lot of fixation in the distal pole. There is some comminution, but that's irrelevant. It's got a lot of hold on the distal pole. There is absolutely no purchase in the proximal pole. And consequently, you're now seeing micromotion there. So if you look at the scaphoid at the proximal part of the scaphoid, you're seeing this lucency developing there, which tells you that the screw is moving inside the scaphoid.
Yep.
So that's essentially what you have here. What you have here is probably not bad biology. What you have here is bad biomechanics. So that's what I would say is the reason. I mean, I'll stop at that so we can have more discussions about that.
Okay. So this question you already answered. What could be the cause? Yeah. So that means this is for a revision surgery. Anybody next? How do we proceed? Anyone wants to? Now that he has spoken about, Dr. Sunil has mentioned, Dr. Bharath or Anil, any of you, how do you proceed further?
What's the duration of the
9 months.
9 months?
Yep.
Okay. Right. I mean, revision surgery basically means obviously to change the screw, put in a better length screw in a better axis, and add in the bone graft also. We might not be able to, with the lysis there, we might not be able to really talk of compressing that fracture site, because we need to maintain the length of the scaphoid also, which means if you see the lateral, again, there's some amount of kind of DC there. So, but the most important thing is removing a headless screw is a hell of a job.
Yes.
At 9 months, even at 9 months to 10 months or whatever, or 1 year, it's always a problem.
I don't have the discharge summary, neither I know what company the screw is. So
yes. So that is the most important problem here. We need to explain to the patient, we really need to core out that distal pole for you to get access to the screw itself, for you to remove it. And hopefully it should be loose enough, because you see that lysis, it should be loose enough for it to come out easily. And then I would actually prefer to have an X-ray of the opposite side to check for the length of the scaphoid to be achieved with this patient. That is one guide. Otherwise, we go intraoperatively by looking at the scapholunate relationship, where the lunate has to be neutral so that you achieve the length of the scaphoid. So yeah, revising the screw and putting in the graft, that would be my option.
You want to get any further investigations, imaging or anything? Dr. Bharath or any of you want to get any further imaging?
X-ray wise, the vascularity looks good.
Huh?
So, sorry, Bharath, please.
Yeah, on the center image, you could see mild sclerosis of the proximal fragment here, or it could be just the exposure problem. So maybe I would do a CT scan to look at the personality of the fracture, the capping, and cystic changes, and then I would agree with Sunil and Anil. Yeah, revise it, the same approach, remove the screw, and most important is to retain the length of the scaphoid, because there seems to be a decrease in the length and compression here. So retain the length of the scaphoid, put in a wedge graft, and then once you reconstruct the structure of the scaphoid, the good corticocancellous graft, it should go in for union. Yeah, and then most important is it's not just by doing a CT or MRI you see the vascularity. Look at the punctate bleeding on the table, on the operating table. Look at the punctate bleeding from both the proximal and the distal fragments. And of course, CT might be able to guide you in looking at the trabecular structure, which may help you in assessing the aortic necrosis. But of course, we don't follow the method of doing the histopathology of the tissue to establish necrosis. That's not required. So just a punctate bleeding on the table, remove the screw. As Anil mentioned, there's lysis. It should not be, of course, this can be a trouble, but be prepared. Remove the screw and then revise it and reconstruct the scaphoid in terms of length, alignment, and get back all the angles right.
If I can
Darshan, any clinically? Oh, sorry, Sunil, please.
Darshan, do you mind going back to that X-ray? I mean, this is a good teaching point that, don't get lost in only what you are seeing. If you notice, this patient also has a distal radial ulnar joint disruption. there's a subluxation there and there's a proximal collapse of that radius. So I wonder whether when this patient had a scaphoid fracture, there was also some sort of a Galeazzi fracture.
Distal radius, yeah.
No, the views were, I totally acknowledge you are this thing, something wrong with the views, I guess, but he had absolutely no symptoms, because when I saw also this X-ray, I thought he was referred for that issue. So then when I checked this thing, I assumed initially the X-ray probably it must have been united and got a fresh X-rays. So that was, DRUJ is absolutely fine. So it's
what about history of smoking, Darshan? History of smoking.
Young chap,
I think the first important take-home message is, I think, to all of them.
No other comorbid. No other, absolutely no other
advise them to avoid smoking if at all he's a smoker.
The other question I would like to ask
keep in mind the remote chance of infection also in these patients.
Okay.
With that lysis, and intraoperatively there might be a surprise of an infection.
No, luckily, actually, the doctor mentioned, Sunil mentioned, lysis is only in the distal part. The proximal part seems to be okay. But definitely, I would agree. All those things have to be borne in mind whenever such a patient comes. I would like to ask all the speakers, what is the percentage of, because of the revision surgeries, these type of cases you come across, or what is the cases, how many or how frequently do you see these type of revision cases when they fix it for this thing and they come in for Dr. Sunil, Bhat and Bharath, how many?
I already gave you my revision surgery rates. Now for the type 1, my revision is 0. For type 2, it's about 5%, and type 3, it's about 6% revision. But I do get a lot of patients
referred. Yeah, I understand. Yeah, that's what. Yeah.
But again, really, we are the wrong people to be quoting
as a gauge. Yeah.
Statistics, because our referral base is anything which is within 2 hours of flying distance of Louisville, which means anything which is within 500-600 miles of Louisville, or maybe 1,000 kilometers of Louisville, comes here. So we get a lot of these.
Okay.
So yeah, we get what's called a selection bias. We see all the bad.
Yeah, I agree. Yeah.
But I would.
And Darshan?
5 or 6% revision.
Okay. Yeah.
And Darshan, yeah, my revision is I've revised 2 scaphoids so far in the last 500 cases in 20 years. And then maybe they would have gone to somebody else.
Okay.
Yeah, and of course, you reconstruct the scaphoid well, compress it well with a good bone graft, assess them well. Yeah. Likely to come in for a revision. Yeah.
When I saw this, even when I was preparing this lecture, because this thing I also looked on the literature. So it was one of the materials. This is almost the revision rate. This was a Taiwanese paper. Maybe I'll tell some more points on when I go further. So this was the revision rate. 8 to 10% of these scaphoids which have been operated are tend to go for. That's a huge number. I felt 8 to 10% is significant. Of course, there was a lot of bias in that also. But now what to do was like, what are the options we discuss? Osteosynthesis or salvage. So it's clear that everyone wants to do osteosynthesis. So I went through a volar approach. I had to get out the screw because this was the only loose part I could not access so easily, or else I would have disrupted this distal pole completely if I had made an attempt to remove my screw there. So I just entered there. I just put a guide wire through that. Then this was the screw size. It was quite small. It was hardly 16. That was the size of the screw. And finally, so preferences of bone graft, I used just a iliacus bone graft, distal radius bone graft there itself. So this was the union. This was a post-op, immediate post-op. I used a volar approach and did this. So 3 months follow-up. This was a reasonable union, and he was doing fine. And you see that the DRUJ is okay. So some of these, this was a paper which I saw, this was in 2020. So some of these, which gave us the revision rate. So it all depends on some of these drawbacks of this study was they did not discuss the fracture type and the patient selection, whether the insurance and the type of fracture. And this was the number of patients they studied in this paper. So failure rate with vascularized was 5%, non-vascularized was 6.5%, 6.1%. So roughly we can take it as maybe 8 to 10% that was. And age and comorbidities did not affect the type of bone graft. This was another thing which was mentioned in the literature. So I think that was these were the cases. So I have, yes.
Thanks. Do you have any questions from the panelist?
Huh?
Do you have any questions from the panelist?
Darshan, what was the latest X-ray? You didn't show us the latest X-ray.
that was the last follow-up I get. These chaps, once they get the union, no, they don't turn up. They find it's hard
Yeah,
to
I deeply appreciate Sunil's observation of that Galazi type.
Yeah.
I really appreciate that because you see it was partly subluxated.
Yeah.
And all, but
now you can
now,
notice.
how old now this post-op X-ray?
This is 3 months follow-up.
3 months, okay.
Yeah.
Do we need to follow up further for that? Are you sure about that union now?
Yes, I think that's good enough. Unless any of you guys have this thing.
No, that little jutting portion, is it a bone graft or is it a union that's showing?
This is a small bone graft. Even pre-operatively, there was a small.
Because I'm not very sure about the union.
It's probably a part of the graft extrusion. What I have here, small one.
Yeah. Okay. Because on the top of the screw, still, I think we need a little more follow-up on this, isn't it, Darshan? I mean, I'm sorry. If
No, definitely. I would have been happy to show some of follow-up, but I had only this what I had. Definitely, I agree. 6 months at least.
Yeah, because at the fracture side, you see some sort of sclerosis already there.
Maybe
on the inner part.
Maybe I would have been happy if I could get a CT scan. I would have been happier.
Fine. Fine. But anyway, tough job. Good done. Well done.
Yeah, maybe you can follow up and get back to clinical results, Darshan. Yeah. Because many times you see union at the end of 6 months, may not be 3 months, end of 6 months you see good consolidation.
Yeah.
Dr. Suryakanth, do you have any questions to ask? So I have a question, sir. Do any of you still use a iliac crest bone graft? If so, what is your indication?
Shall I?
Personally, for me, I've been always using distal radius graft, and I've never had issues with that. Never had problems. It's just an extension of incision. Either if you're doing volar or dorsal approach, any of these approach, you just have to extend the incision and take the graft. And we've just sent a paper for publication where we have about 38 or 40 cases. We've used only pure cancellous grafts, nicely impacted cancellous grafts in almost all levels of non-union. And we've had very high union rates in any of these. So my personal preference would be distal radius graft. Very early in the practice, I used to use the iliac crest with spinal biopsy needle and used to take a core of it and used to use it. But nowadays, only distal radius graft.
So none of you
Yes,
use. Yes, sir, Dr. Bharath, sir, you can go ahead.
Yes, I agree with Anil, and Darshan, most of the time distal radius is enough. Only the exception is a small wrist and a large structural defect. You do not want to mess up the distal radius when you have a small wrist and a large structural defect. And then when you plan it well, you need a large, big size wedge grafting, but you can always go and take a iliac crest graft.
In a case of established non-union and collapse, so how do you maintain the length? You said you will use a graft there. So how did you really measure the length of the scaphoid, or what is the criteria?
Can I this thing? Roughly, we did a cadaveric study to know the length of the scaphoids. Actually, one thing I saw was the ring finger, the middle phalanx. That's roughly the length of the scaphoid on an average. You can take the opposite side, but still measuring on a X-ray is quite difficult to exactly because of all these issues. So either you want to get the exact length you want to know, you have to get the opposite side CT to know the exact length. Even an X-ray may not give you the exact length of the scaphoids with it. So that is one thing. This middle phalanx length is typically the length of the scaphoid which you want. So you can know that is one thing. And second thing is you need to intraoperatively, we need to correct the deformity whenever the lunate. So that is scapho-lunate relation. No? Once you establish that, that tells you that that's the correct length what you want.
And during your non-union surgeries, your screw is basically a positional screw rather than a compressive device. So you know the length you need to achieve. So you need to have a screw size which will basically keep the two fragments in position, and then you fill in graft as much as possible. So that's another way of also achieving the length.
One more thing is typically usually the Indian wrist, the screw length doesn't exceed more than 20 or 20. If the minute you're crossing 22, you need to know that something is wrong. You need to check again. Either you're out of the track, or so 18 to 20 is the usual size in India. What we use are typically the screw size commonly used. 22 and above, think twice. Means you recheck it.
Sir, Darshan.
Yes, sir.
Screw, is it a compressive screw or a what? Regular this thing? This
is a headless screw, headless compression screw, sir. This is a headless compression screw.
Yes, so but okay.
Differential compression.
Okay.
It's a differential compression.
The Synthesis has HCS as a usual.
Okay. Okay.
There is a question from the audience. If you have a humpback deformity and you want cortical wedge graft, is the distal radius graft enough to take large wedge from? Definitely no. I mean, if you want to have wedge, cortical construct to come into there at that point, and if there's a loss of bone in terms of a lot of comminution and bone loss and cystic kind of a loss there, you would want to have a tricortical graft from the iliac crest. Your distal radius won't give you that. If you want pure cancellous graft, you can use the distal radius. That's a question from the audience there. Vamsi, can we go ahead with the last talk?
Yes, sir, we can go ahead.
Bharath, so are vascularized grafts still in vogue, or it's given up? I think Bharath.
Yeah, no, thanks, Darshan. It's a wonderful presentation.
Thank you very much, sir. Thanks. It was a pleasure to be part of it. Thank you, sir.
Is my screen visible?
Yes.
Yes, sir, it's visible.
Yes.
Am I audible?
Yeah.
Yes, sir.
Yeah. In the first place, I would thank the KOA and the team for bringing up this webinar on scaphoid. And since all of us are talking on scaphoid, there would be some repetitions and overlap. See, it's well known that vascular bone grafting for any non-union is still in vogue. It's been decades that you know that vascular bone grafting does work for non-union, but now we'd like to assess whether is it an overkill for scaphoid non-union? Is it really required? How often is it required? And what are those special indications where it's required? Now, here is the patient who presented with the scaphoid non-union at the waist. See, he underwent surgery in September 2016 by the first surgeon, put in a screw, and then he felt that it's not uniting, and the surgery in December, that is 1 year, 3 months later, went and put in some bone graft. And then the third surgeon went and put in some multiple wires because it was not uniting. And then the fourth surgery was, all the wires were removed. And then at the end of 4 surgeries, the patient was left with a scaphoid, which is avascular and a painful wrist. Retrospectively, could we have done something more to ensure to salvage the scaphoid and the wrist? Here's another patient, 17-year-old boy presented with fall in the outstretched hand. Initially, it was not diagnosed, but came back to me 9 months later, and X-rays showed a fracture of the proximal pole. As all of you can appreciate that, with pain and reduction in the grip strength. Well complemented with the MRI, where you can see the avascularity of proximal as well as part of the distal fragment also, as you can see here. So went ahead and did in the 1-2 suprareticular artery, the Zeidenberg's flap, as SUNIL, Darshan mentioned. And since the fragment is small, could not fit in a screw, so I used in a 1.1 and 1.2 mm K-wires to be kept ready for a small fragment where we are not able to was in a screw. So 4 months post-op X-ray, the good union, and at the end of 1 year, at the end of 2 years, there's reasonable range of movements and restoration of the grip strength. So there is enough literature to suggest that vascular bone grafts have demonstrated utility in promoting consolidation in the treatment of scaphoid non-unions, which are complicated by avascular necrosis. And if you look at this paper on the meta-analysis of literature on the scaphoid non-unions, vascular bone graft had a union rate of 88% versus 47% with the screw and wedge fixation. So but there's enough papers to suggest that with the advent of minimally invasive technique, that is arthroscopic bone grafting for scaphoid non-unions, the need for vascularized grafting is reduced, particularly in PCO's paper, where it uses the minimally invasive technique. And explanation is that the blood supply of the capsule is preserved. And even if there is avascular with the fragments, a minimally invasive technique is good enough to restore and salvage the scaphoid. So does anyone need a vascularized graft? Now, if you look at this work published in 2019, there are multiple series of outcomes, which almost a meta-analysis of the multiple outcomes which are presented between vascularized bone graft and a non-vascularized bone graft for scaphoid non-unions. And the conclusion in 2019 May is there is no evidence to show significant differences in union rate or time to union between vascularized and non-vascularized bone grafting. And it also says that future comparative studies should have a control for the proximal fragment size, the fixation methods, and the bony defects. Again, that leads us to the basic question, what is avascular necrosis and how do you diagnose that? Well, is it enough to have signal changes in the T1 and T2 weighted images in the MRI? And this paper further goes on, explains that it is not just enough to have a signal changes, but what you have to look at is a punctate bleeding at the fracture fragments on the operating table, which is going to decide the vascularity of the fragments, the histopathology of the fragments which establishes necrosis, meaning that there is avascular necrosis, and also the trabecular structure on the CT scan. So maybe both MRI and a CT will help you to assess whether there is any vascularity. So the indications for a vascular bone graft boils down to non-union with avascular necrosis, previously failed surgery, because the patient is already operated once, twice, thrice, you don't want to mess up with him again, and then you would always prefer the vascular bone graft because the chances of union are better. And of course, in proximal pole non-unions, where the vascularity is low and they're highly prone for avascularity and non-union, you would want to prefer to a vascular bone graft, particularly if they're already into avascular necrosis. So what options do you have? On the dorsal side, you have the 1-2 intercompartmental, the 2-3 intercompartmental. You can also take the second metacarpal base. And then on the volar side, you have the branch coming from the radial artery, the volar carpal artery is called, with the ulnar branch of the ulnar artery, and you take up the ulnar volar corner of the radius. You can also use the pronator corder as muscle pedicle graft. And the other option is the free vascularized bone graft from the medial femoral condyle. It's well established that there is a combination of proximal, reduces the carpal collapse, and also well proved for a scaphoid non-union surgery. Based on the descending geniculate artery, medial femoral condyle. And there is a structural defect. Now, here is a medical student who presented with scaphoid non-union, which was 7 months since the time of injury, a third-year medical student, and MRI was showing avascular necrosis not only of the proximal fragment but also of the part of the distal fragment.
Okay, fine.
And Darshan has already showed the schematic representation of the 1-2 intercompartmental artery. In short, we let us go, and that's my incision usually along the APL tendon. You'll be able to see the recurrent branch of the radial artery, which goes over the 1-2 intercompartmental the compartments, supraretinacular intracompartmental artery. And that the vessel over the fascia and between the first and second compartments. We divide the fascia on the ulnar and the radial aspect, and then you mark a bone graft around the nutrient artery entering the bone. Use fine osteotomes to select the bone graft which is attached to the pedicle, and then carefully dissect it distally, because you need a good length to reach to the site of the scaphoid non-union. Make sure you take enough cup of tissue, and that's and most important to remember, they're curating the site of the scaphoid fracture. Well, fix it up with a screw, and then you mobilize your vascularized graft with the pedicle vascularized, the Zeidenberg's flap. You need to do a little trick where dorsiflexion of the wrist. So to mobilize the graft under the tendons, and then fix the graft with a K-wire just to hold it in place, or it can also fit like a press fit. And that's how the post-op picture looks. The screw is inside this one, whereas the KOA is just to hold the graft in place. And it's important to, when you do a vascular bone graft, it's a good practice to release your tourniquet and have a look at the bleeding of your vascularized bone graft. As you can see here, just pour in some saline and then see this punctured bleeding coming from the graft you've taken. So 6 weeks of short term spica cast when you do a vascular bone graft, and of course the visual later on, and the end of 1 year you can look at the follow-ups. The volar aspect, you can take the orthopaedic artery popularized by Methola, who's done it in 111 cases, proved that union rates are 96% in non-union and 89.9% in patients with non-union and avascular necrosis. So all patients reported better union with the vascular bone graft. And here is a patient who presented to me 9 months after injury. You can see the waist non-union here. The cystic changes obviously in the CT scan and also the MRI showing signal changes in both T1 and T2 weighted images. And that's the medical is already pointed out. This the orientation is right. On the left is your distal part, on the right is your proximal aspect. And then this is the radial aspect and the ulnar aspect. And you have the radial artery branch coming out from there. It goes along the distal edges of the quadrilaters. And you export the fracture site at the same incision, holistic Jain incision, and then curated it well. And then you see how you mobilize the graft elevated with the orthopaedic artery along with the cuff of tissue there. Mobilizes well, that's from the distal radius, mobilizing to the fracture site. That's the vascular bone graft from the volar aspect, the volar carpal artery. And you fix it with the rubber screw, good compression, and then wire is just to hold the graft in place. So the take-home message is basically, it's a decision, it's based on a case-to-case basis. We'll have to take decision on a case-to-case basis. And the duration of non-union is very important. Patient with a non-union coming of 3 years, 4 years down the line, very likely to have a avascular necrosis rather than just a non-union. And the size of the proximal and the digital fragments also matters, because when I told you that when the proximal pole fracture, the small size is very likely that it could be avascular. And assessment of avascularity is not just on MRI, but also on the intrapunctate bleeding, where you on the table decision. Also, the methods of fixation unit also matters, help you to aid in taking a decision whether you need to do a vascular bone graft or not. So remember, revascularization is akin to reincarnation, and it deserves its due respect and sanctity. So let's honor this and use it for cases which really require a vascular bone graft. Thank you one and all.
Thank you, Dr. Bharath, for the excellent demonstration of the vascularized bone grafting. The talk is open for discussion from the panelists and the faculty also.
You said the evidence says there's no role of vascularized bone graft in a frank non-union, but in the second case you used a vascularized. What is it?
Yes, yeah, that's because I've been used to using vascular graft for almost 1.5 decades now. But the decision now is basically based on the duration of non-union. It's case-to-case basis, is what I said. But most of the non-unions is what I said. Whenever there's a structural collapse or a defect, cystic non-unions do not need a vascularized bone graft. So you need to, and just doing an MRI showing signal changes in both the T1 and T2 weighted images is not enough. And what Sunil mentioned that MRI with contrast certainly helps in establishing the avascularity. And what most important I feel is on the table you need to freshen up the fracture site, look at the punctate bleeding, and then take a decision of whether you need a vascular bone graft. So you have an option of taking a vascular bone graft from the volar aspect, from the dorsal aspect. So there's no problem at all. So you can do it. You can add on as a supplementary procedure when you think it is required. And particularly in a proximal pole non-union presenting late, invariably they have some avascular necrosis, and you would certainly want to take a chance and subject the patient to a repeated surgery.
Rajendra, one. Yes.
Yeah. No, just thank the Sunil. No, I don't have any questions because this is more super specialization for us, honestly. No, it was a wonderful this thing. I just wanted to appreciate all the speakers. It was wonderful lessons for us rather than anything. All the 4 speakers, fantastic it was. and all. I don't know if there's any questions from the other people.
There's one question from the audience, Bharath. In case of very small proximal fragment that can't be fixed with a screw, any role for excision of the fragment only without replacement, with any graft?
Well, if the fragment is very small enough,
Excision of the fragment
just
only
make sure that your scapholunate ligament is intact, because practically it will behave like a scapholunate dissociation. So very unlikely that, usually the scapholunate ligament is attached to the proximal pole. So when you have a proximal pole non-union which is absorbed, which is avascular, so likely that part of the ligament is, when you excise the fragment, that part of the ligament is gone. So you are leading it, it may go in for a scapholunate dissociation. So I would actually prefer to either excise and do a supplementary procedure like a scaphocaprate fusion rather than leaving it alone. Unless until you are very sure that it's a very, very, tiny fragment where the scapholunate ligament is intact and there is no instability, carpal instability. But the replacement part, I've not done a replacement of the scaphoid with the silicone. Some people already use this tendon tissue where you replace the fragment. I don't believe in that, because invariably that will go into a carpal instability and that doesn't really work. So if you decide to excise the proximal fragment, you need to give stability by doing a scaphocaprate fusion.
Dr. Sunil, your experience on that, very tiny fragments, would you reattach the scapholunate ligament?
If it's a very tiny fragment, I would rather wait and see if it goes into a fibrous union. Now I'm talking about a proximal pole. I mean, if it's a distal pole, you can leave it alone or excise it. You can also try what's called an osteochondral graft. You can try to harvest it from, like the head of the metacarpal, which provides you with that, or from the captate. You can try to harvest a little core of osteochondral graft and try to put it in there to replace it. But realistically, if that fragment is very, very small, I would prefer that it goes into a fibrous non-union, because if you try to remove that, you may end up with a cartilage defect exactly at the only spot in the scaphoid where you don't want a cartilage defect, which is the proximal pole. Scapholunate instability may occur over time. I haven't really seen that happen, because if it goes into fibrous union, you're pretty fine. But this is one instance where you might end up having to use a K-wire to fix your fracture, because you can't really hold that fragment with a screw. And as I showed in my lecture, I do not use vascularized bone grafts unless there is avascular necrosis. The only time I would use a vascularized bone graft is when there is still vascularity, is if I have already done a primary fixation or a non-union fixation with standard bone graft and that failed. So that's a very, very, very small percentage of patients really. But proximal pole, yeah, maybe you can try a K-wire, or I would strongly prefer to let it just go into a stable fibrous union.
Thank you, Sunil. Suryakanth, sir, any questions?
No, thank you.
Any other panelists?
Yeah, Dr. Sunil.
Yes, sir.
Yeah, that was a beautiful presentation, as always. Before also I've seen. You are one of the best presenter, I feel. And thank you for coming. Thank you.
Well, it's my home organization. I think my life membership number is 125. So I'm the 125th life member of KOA. So,
we should meet next time. Next time you come to bank.
I mean, what I take home message is these are such high specialized jobs. I think it's not the cup of this thing, general orthopedic surgeon to do this. I mean, these are really so tough. Unless you have a big number to do that, I'm sure a one-time surgeon will always fail with this. The best thing is to refer to these specialized centers.
True.
I mean, that's the big moral lesson we have to learn from this.
Yeah, my mentor, Dr. Harold Kleinert, always told me in the first 5 years of his career, he never had any complications. So all his success rates were 100%. He retired after 60 years in practice. And he said, By the time I was in my 60th year of practice, it looked like I was only taking care of complications. If somebody tells me that they've not had any complications or if they've had 100% union rate, it means they've just started practice.
That's a good one.
That's a very nice quote.
You're not operated enough, yeah.
Yes, sir. I just wanted to mention that, when I started in Bangalore, I was self-trained as a hand surgeon, and I was doing all this just by myself every night. And Dr. Satish Sherweger was one of the people who encouraged me a lot. I mean, if you remember, I'm talking about 95, 96. We didn't even have memberships or trainings at that time. So I just wanted to say thank you to Dr. Satish for that encouragement. He made me do call every day for 7 years. That's different.
No, those days he had purchased that loop from his own money, pocket money. It was very costly.
I purchased loops on my own. I also purchased micro instruments on my own. There were no micro instruments available. Yes. And I only had a monocular ENT microscope with a 2-foot long, so I had to stand 2 feet and do that. So yes, sir. So, but I just want to, it's so wonderful to see all of you. And, after all these years, I mean, I'm seeing Dr. Uday, I think after almost 20 years.
Yeah, Sunil. Very, very nice to see you.
Of course, I see Anil regularly and he rags me all the time. But.
So I think currently, if you compare what work Sunil, they would probably brand you as inhuman, 24/7 for 7 years in the US, if you compare it now, the kind of work, right? So they would brand you as inhuman. Yeah.
That is for his wife to comment. That is for his wife to comment.
I bought these loops in 1998. It cost me 3 months' salary. I'm still using the same loops. And you can see I've got circlage wire and tape holding my holding apart, but I'm still using these. So
old is gold. Old is gold.
Yes,
no, he's born in India.
Bought in India, I remember.
Born in India.
Born and bought, yeah.
Bharath. Raju will do the closing remarks.
Yeah, I think you did. You put some. Thank you.
Thank you, one and all. It's been a great enlightenment regarding scaphoid fractures. I'm sure it is going to help all the general surgeons regarding management of scaphoid fractures. First of all, I would like to appreciate and congratulate Dr. Chandrashekar, who's been actively organizing academic events of COVID times. This weekend, we are having 3 events. One is this webinar. We just finished one CME and workshop, hands-on workshop on pelviacetabular fractures in the morning. And tomorrow, there's a postgraduate teaching program happening. Thank you, Chandru sir, and keep up the tempo. And I would like to thank Dr. Sunil, who's taken off time from his hectic schedule and been a part of this webinar, and hope to see you more in the future, Dr. Sunil. I also thank our very own hand surgeons from Karnataka who are with us always, Dr. Anil, Dr. Bharath, and Dr. Darshan, for a wonderful presentation. I thank the panelists, Dr. Uday Kumar, Dr. Rajendra, Dr. Suryakanth. Thank you, sir. A special mention to the coordinators of this, Dr. Satish Sherweger and Dr. Vamshi. They have been continuously preparing for the webinars every month, coordinating with the speakers and all that. It's a hectic job, sir. Thank you. A special mention to Vamshi. He's been the go-to man regarding webinars now due to the pandemic. Thank you all for a wonderful presentation. Hope to see you all soon. Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you all. Yeah.